Hey there, want to make your voice heard at a Board of Supervisors meeting? We're all ears. Here's how you can get involved. First, hop online and look at the agendas. This will give you the scoop on what's coming up before the board. Each agenda item includes a brief description of the issue, the recommendations, and potential impacts. If you need more detail, check out the detailed reports online. Those are called board letters. Then, decide if you want to speak at Tuesday's general legislative session or Wednesday's land use session. You'll have 3 opportunities to have your say. Let's start with non-agenda public comment. This is your chance to talk about things that aren't on the agenda, but try and keep your topic related to county government. For non-agenda public comments, you can speak at either the Tuesday or Wednesday session, but not both. So pick your day accordingly. And keep in mind, the board can't act on the spot. They'll refer your comments to the Chief Administrative Officer, who will look into the issue. Last thing, the board will hear from the first 10 speakers, 5 in person and 5 by phone at the beginning of the session. Then all the remaining speakers will get their chance to speak after the discussion items. During the consent agenda, the board handles a bunch of routine items with 1 vote. If you want to comment on an item, keep it simple. For example, I'm John Doe speaking on item 5, and I agree with approving the contract. Discussion items are the main event where the board debates before making a decision. Want to speak at one of the meetings? It's really easy. Just hop online and fill out a quick request form at publiccomment.sandiegocounty.gov. Pick the meeting you're interested in, hit the register button, then fill in your details. Make sure to include a phone number if you plan on speaking by phone. Prefer speaking at the podium in the board chamber? No problem. Just pick the in-person option. After that, just check off the agenda items you want to talk about and let them know you're for, against, or neutral on them. Hit register and you're good to go. A confirmation email will land in your inbox to wrap it up. If you're speaking by phone, the email will include the instructions for how to dial in. Be sure to submit your request early. Once public comment begins on the agenda item, we can't take any more requests to speak. And if you have documents, hand them to the deputy clerk when it's your turn to speak at the podium. Now, you get 2 minutes to speak, but if lots of people want to talk, it might get cut to 1 minute. So, you might want to consider writing 2 sets of comments, one for 2 minutes, another one for 1. That way, if time's cut, you won't be scrambling. There's also a countdown clock at the podium to keep you on track. Once you're at the podium, stay on topic. Stick to the current agenda item. If you stray off topic, you might get a gentle nudge to get back to the point. Keep your comments related to the agenda item's recommendations because that's what the board is relying on to make a decision. Also, speak directly to the board. They're the ones making the decision. When your time's up, it's up. Overstaying might mean getting muted or even asked to leave. Now for some ground rules. For safety, keep aisles and doorways clear. If there isn't a seat, head across the hall to room 302 or the 4th floor balcony to watch the meeting. Respect is huge. Everyone should feel heard. That means you, other speakers, and the Board of Supervisors. Disruptive behavior gets 1 warning, and after that, a deputy sheriff might show you the door. So let's keep it respectful. Your voice matters, and we want to hear from you. Remember, we're all here to make a difference.
morning. I now call the March 25th, 2026 San Diego County Board of Supervisors Land Use Legislative Session and Sanitation District meeting to order. Andrew, please call the roll for today's session.
Thank you, Chair Lawson-Remer. Supervisor Anderson is absent today due to illness. With that, Supervisor Desmond.
Here.
Chair Pro Tem Aguirre.
Here.
Vice Chair Montgomery Stepp.
Here.
And Chair Lawson-Remer.
Here. Before we begin, I'll take a moment to address our House rules. Public engagement is the cornerstone of transparent and accountable government, and these Board of Supervisors meetings are our primary venue where all San Diegans can make their voices heard. Our county is committed to a work environment free from unlawful discrimination and harassment, including sexual, racial, religious, age, disability, or any other form of discrimination or harassment. Under the board's rules, speakers may not use loud, shouting, threatening, impertinent, slanderous, profane, or abusive language to any member of the board, staff, or general public. Additionally, all remarks and questions must remain on topic during the duration of your speaking time and must be addressed to the board and not to county staff. Any speaker who engages in comments that breaks these rules will be issued a warning. After one warning, you'll be asked to leave the chamber for the remainder of the meeting. Speakers threatening violence may be reported to law enforcement and removed. This is a space for community engagement, deliberation, and progress, not harassment, violence, and hate. Today, we begin with item 26, which has a time certain of 9 o'clock. Then we will hear items 27 and 28 as they are related to the topic discussed in item 26. Then we will hear the remainder of the items from yesterday's session in numerical order. Then we begin our land use legislative session. Land use legislative session with non-agenda public comment, the consent agenda, and then discussion items 9 and 10. Okay, go ahead. We now move on to discussion of item 26, receive update and presentation from the Social Safety and Behavioral Health Transformation Ad Hoc Subcommittee. I'll invite to the floor J.C. Cooper for a presentation.
I'll actually kick it off for us. Thank you so much, Chair Lawson-Remer and members of the board. The county is navigating a period of significant change at both the federal and state levels, with updates to Medicaid, behavioral health funding, and social services programs that directly influence how counties plan and deliver essential supports. In recognition of this evolving landscape, on August 26, 2025, your board took action to establish the Ad Hoc Subcommittee on Social Safety Net and Behavioral Health Systems Transformation. The charge was clear: to undertake a comprehensive and deliberate review of the systems that form the foundation of support for San Diego County's most vulnerable residents, and to develop recommendations that strengthen and modernize those systems. As this work has advanced, it has become increasingly evident that we are operating within a complex and rapidly changing policy environment. Recent federal developments, most notably H.R. 1, representing the most substantial changes to Medicaid since the Affordable Care Act, carry significant implications for counties throughout the nation, including our own. While the county team possesses extensive internal expertise in eligibility operations, enrollment processes, and program administration, the breadth and complexity of these federal shifts necessitate additional external perspective. In particular, county staff identified the need for expertise grounded in firsthand experience with how federal and state policy decisions are shaped, implemented, and operationalized, which is essential to aligning county systems and resources to best serve our most vulnerable residents. Accordingly, staff sought specialized consultation to support the Ad Hoc Subcommittee in achieving the outcomes directed by the board. We are fortunate to secure the partnership of J.C. Cooper with Precision Health Strategies, whose background, leadership, and depth of experience align uniquely with the county's needs. Over the course of more than 2 decades at the federal, state, and delivery system levels, J.C. has been at the forefront of some of the most influential Medicaid reforms undertaken in the country. Most recently, she served at the Centers for Medicare and Medicaid Services, where she led national efforts to support state innovation and provided guidance on complex waiver authorities. Prior to that, as California's Medicaid director, she played a central role in the design and implementation of CalAIM. County staff has collaborated closely with Ms. Cooper in preparation for the Ad Hoc Subcommittee meeting on February 11th, where she provided critical context to help frame both the challenges we face and the opportunities ahead. Her insight has already proven highly valuable to our work. At the last Board of Supervisors hearing on March 3rd, members of this board expressed interest in receiving that presentation in a broader forum, and we are pleased to bring it forward today. With that, I will turn the presentation over to J.C. Cooper.
Thank you so much, and thank you for having me here today. I think to say that H.R. 1 was one of the largest changes to both the Medicaid and I would say, and additionally, the CalFresh or SNAP program is an understatement. As an overview, I'll walk through the changes at the federal level, as well as how that's going to be impacting both state and counties, as well as some considerations as San Diego looks to reevaluate and reassess their 17,000 mandate. Overall, California has publicly come out saying that the changes under H.R. 1 could make up to a $30 billion annual reduction of the state budget and about $3.4 million across both Medicaid and Marketplace in regards to potential loss of coverage across all of these pieces. That's a very large scale view from the state. I'll kind of walk through what that may look like for San Diego and some considerations to make sure you're understanding all the moving parts in regards to H.R. 1. Next slide. So this is just a snapshot that I believe you've seen before, but this will show you both implementation dates as well as policy changes, as well as the San Diego specific estimated impact across these various changes. As you can see, there are significant changes happening in 2026 and a very large grouping of eligibility changes tied to the Medi-Cal program and work requirements in 2027. The compounding fact of all of these across both Medi-Cal as well as CalFresh will be putting some downstream fiscal pressures on counties as they are implemented. The nice thing is there is some time within 26 to be preparing for those various initiatives, which is great. And San Diego is really leading the charge, I would say, in the state in regards to being proactive in regards to this. So I do applaud you in that effort. But I think preparation is going to be really important to be able to travel through and have a good strategy as you navigate these very large changes. And I will walk through these in more detail in the previous slides, but this is just a snapshot so you have an understanding of the impact here. Next slide. Perfect. So before I get into the county-specific items, I think it's important to have some perspective on the larger fiscal changes that are coming out of H.R. 1, because this will put some significant potential pressure on San Diego County in regards to changes that will directly impact hospitals across the entire state of California. One of the changes that happened in H.R. 1 is there's some significant changes to how states can use provider taxes in the Medicaid program. Essentially, the feds have dropped the regulations at this point, and California will no longer be able to have their provider tax after the end of this year, so calendar year of December of 2026. The provider taxes provide a significant portion of dollars to the Medicaid program, where the state's not putting in that general fund at this time. It's coming through the tax itself. So what that means is that will create a hole, a large budget hole for dollars that were otherwise going to hospitals or managed care plans. The ones going to managed care plans are funding rate increases for a variety of providers across the Medi-Cal program. The dollars going to hospitals tied to these various provider taxes is helping fund hospital dollars. There will be very big shifts in regards to those. It varies across hospital and the managed care organization tax, but it's important for you to have perspective in regards to those changes, because that over time, they will phase down over time. It's not a cliff, which is good. It gives time for various measures to be looked at, but it will create fiscal pressures within the entire state ecosystem. The next one is what's called state-directed payments. And this is how in the Medi-Cal program, many hospitals receive what's called state-directed payments, and they receive these funds coming in. There's also been a new cap added onto state-directed payments in H.R. 1, essentially capping at 100% of Medicare for expansion states. California is an expansion state where we've expanded to the adult population in the ACA, and that will have to be phased down as well. For non-expansion states, it's capped at 110% of Medicare. California was receiving more than 100% of Medicare in their state-directed payments, as that was the previous federal law that allowed for that. And so again, there will be additional reductions in addition to what you're seeing in regards to the potential impacts tied to provider taxes. So a double whammy for our hospital colleagues across the state of California, and then on the other part, some of our other colleagues who are receiving rate increases. You'll also see there are new share of costs, so the state will have pressures in regards to reductions of state of cost around the various populations who have unsatisfactory immigration status, and they have taken certain populations out of eligibility for Medi-Cal. And so this is just giving you some perspective on the overall state budget pressures that will happen, as well as budget pressures you will see from various providers in your community over the next few years as we move through these various phases of implementation here. Next slide. This next is to provide you an overview of things that will most likely, or not most likely, will directly impact the San Diego County. So the first one here has already gone live, and this is the Medi-Cal freeze on the full scope enrollment for the UIS population. In addition to federal changes, the state of California is also in a relatively tight budget situation, which is getting compounded by the federal changes on top of that. And so you're also seeing the state needing to make measures and changes to reduce their budgetary impact across state-only programs. This is where the state of California is using their own 100% of state general fund to fund various pieces, especially when it comes to people with unsatisfactory immigration status in regards to coverage and access. So you're seeing some shrinking here in regards to who will have access to those services. You'll also see that at the federal level. So the federal level is also making restrictions in regards to individuals with the UIS, both on the CalFresh side and work requirement side. You will see some of those changes hitting in April of this year and then later in June. So you will start seeing changes on the CalFresh side are the earliest changes that the county will meet. What I'd say is I've been working closely with your team since coming on, and they are doing so much to prepare for the changes in April and in June, which is great. They're being very proactive on communication plans and building pieces, which will be really important because you want to make sure you're educating the broad public as well as impacted beneficiaries in regards to these changes, because you don't want to have cliff on benefits when now someone has to meet a new work requirement in order to maintain access to their CalFresh benefit. That can have significant impacts on a household, as you would imagine. And they've been doing a lot of great work to get information out, to prepare for that change, to inform people. And so really important to be paying attention there. Additionally, HR 1 also changes the administrative cost sharing. So you will see an increase in regards to the state will also see the increase in regards to what the state is expected to put in. And so that will then have downstream impacts onto the county. I know you were briefed on that earlier this year and last year in regards to those exposures. It really will vary in regards to what that could look like in regards to decisions the state will make through their budget process and then eventually down to the county as well. One of the largest shifts that you're going to see in HR 1 is around the Medi-Cal program. So the Medi-Cal program in California covers around 15 million lives, or around 33% of the lives in California. And there are three very large changes all going into effect on January 1 of 2027. That is where work requirements will be a requirement for individuals who fall into the adult ACA expansion group. There are exemptions for certain populations, for example, someone who is in substance use disorder treatment or has a serious mental illness, medically frail, someone who is pregnant. So there are exemptions for this work requirement. There are also short-term hardships for certain individuals as well that will apply. California has released some of their preliminary guidance in regards to how they will treat this. It's very beneficiary focused and aimed, which is positive. But if someone does not have an exemption and has to meet work requirements, they're required to do 80 hours of either work, education, or community service in any given month within a 6-month period to be able to maintain their Medi-Cal coverage. This is the first time that you are having something other than income and assets determine the eligibility for the Medi-Cal program. So this will be a significant change. While work requirements has existed in the CalFresh program for quite some time, even though there was waivers for many, many years on that front, this is the first time this will ever exist within the Medi-Cal program. So the amount of education to the public will be significant. The state of California in their budget has earmarked a very large statewide campaign, similar to what happened in the unwinding. And so you would imagine this will also be front and center to make sure people understand understand this significant change for the adult population as well. The other thing that's happening is HR 1 changed it from redetermination every 12 months to every 6 months. So that high frequency and increasing the frequency of redetermination historically has shown that you see a higher level of churn. So on top of now work requirements, as well as a 6-month determination, you're going to potentially see a significant number of people falling out of coverage and then eventually turning back to coverage when they need, whether it's medication, treatment, or services, which has shown to be very costly, to be honest with you. There's a lot of research that shows that can be very costly. So the confounding factor of the work requirements in the 6-month redetermination could yield that large number of loss that California is currently estimating could happen with the implementation over time in the state of California. And then the other part that they changed is there used to be an allowance for a 90-day retro coverage period. Because churn happens in these types of programs due to administrative friction, you used to be able to retro back 90 days to have that coverage so that the individual doesn't get those charges. They have now reduced that for the adult population to only 1 month. So it'll now go to a 30-day retro period instead of the original 90-day period. And for the non-expansion group, it's been reduced to a 2-month window. So again, changes in regards to these various pieces. The reason why this is so important is those individuals who lose coverage will also be going to various hospitals and FQHCs who are also seeing federal funds restrict for themselves. So FQHCs are also facing additional cuts in light of HR 1 and other changes at the federal level. And so you're going to see a significant increase in uncompensated care in your community. And there will be more pressure on your 17,000 mandate obligation that happens in California and exists. And I'll get through some of those pieces. Some other pieces just to make sure you're also tracking is some benefit matching based on the error rate. So the other thing that the federal government is doing, both in CalFresh as well as Medi-Cal, is they're doubling down on errors, for lack of a better description. So counties are responsible for eligibility, and the state has a role as well, of course. But on the CalFresh side, they're going to be looking at that, and then you are increasing the amount of exposure, fiscal exposure on any of that. And then in later years, it kicks in, 29, that will be happening also on the Medi-Cal side. For decades, the federal government has waived some of the fiscal cost recoupments and sanctions on the Medi-Cal side. They are no longer. They changed that in HR 1, and then so in the future, something to be paying attention to also on the Medi-Cal side. Next slide. So there's a lot happening in light of HR 1 with very tight timelines, certain things that are starting to implement, and then things that will implement over now, between now and 2030. The biggest thing I would say is while the federal statute gives you some information, so people are moving as much as they can, most states are dependent on the federal government releasing regulations to understand the nuances and details of those of the federal law. While DSS has given some guidance to states on the CalFresh side, given the near-term implementation, CMS at the federal level has not dropped any of the federal regulations for the Medi-Cal work requirement changes yet. And so once they do, the state will have to digest those regulations, and then they will issue guidance down to the county. I just flagged this for you so you understand that this will keep evolving over 2026 as we get more information from the federal government in regards to how they are expecting states to implement these work requirements, in particular in the Medi-Cal program, since they have yet to opine. They released some very high-level guidance, but respectfully, it was no different than what was in HR 1. It was just in a little bit easier form of reading than federal law. And so a lot more details to come in regards to what the feds will be providing guidance on. And then that comes down to the county, and the county has to operationalize that. So the staff will be under very tight timelines as that comes down from the feds to the states to implement. Something for you to just broadly be aware of how it works. Next slide. So there's kind of four areas here to be focused on. Really, with the coverage loss increase starting in 26, it's really just to be aware in regards to being planning, in regards to communication, system readiness, and overall understanding of the impacts that are happening within your community here in San Diego, especially focusing on the UIS population in these early years, and then preparing and ramping up for the Medi-Cal work requirements. Also, as I mentioned previously, doing everything the county can to reduce that churn. Because anyone who stays on Medi-Cal is a less of a fiscal and responsibility risk for the county itself through their $17,000 obligation. So you have the largest incentive to make sure everybody stays in coverage, as well as managed care plans will have a huge incentive to keep everyone on. So partnering, for example, with your managed care plans hand in hand to be able to also partner to how everybody can be working to ensure anyone who needs coverage remains covered on those pieces will be critical. And then, of course, working with your various hospital and FQHC partners across the county will be critical for success, because you need all hands on deck to make sure anyone who needs coverage or is eligible for coverage stays covered, because the overall cost is larger if they don't. And this is really where the material fiscal exposure comes in. So it's just being aware of that. The hard thing is there are estimates right now, and there will be a lot of planning, but a lot of that will be evolving over time. And so the team will need to keep you abreast of once regs drop, what does that change? So it's just important to know that those will evolve over the next year. And then really making sure we're not just only focused on the near front, but the long-term exposure, like I mentioned, in regards to the air rate and along to the Medi-Cal PERM changes where there could be fiscal implications or sanctions in the future as well. Next slide. So when it comes to the $17,000 obligation, because California was so successful with their ACA expansion, the uninsured rates were at an all-time low prior to HR 1. So low that most counties had really shrunken their $17,000 obligation programs. In fact, some counties almost pretty much eliminated them because the uninsured rate was so low. Well, with the ramp up of work requirements on the Medi-Cal side and the potential of some significant losses of coverage, there's a lot of conversation happening in regards to counties bringing back and or reevaluating their $17,000 obligation, which is what your board also decided on March 3rd to have the staff relook at this program in light of the significant changes potentially coming down in response to HR 1. So a few of the things that we'll be looking at in regards to that assessment, we need to look at the eligibility and coverage. So usually counties get to define the federal poverty level in which is covered in those particular programs, as well as what types of programs or benefits are offered in that particular package. You'll want to be thinking through things like phase-in, STEP program or tiers. It's very common. Cost sharing. These are all the different scenarios that will be considered. Also, I know there's conversations around the Safety Net Bridge program. There will be interaction between that program as well as this $17,000 mandate. We need to think about those interactions so there's bright lines in those particular areas. So those are pieces we will be looking at. We also want to make sure we're planning for churn and managing costs. Sometimes, even if it's not at the full mandate, it actually will save you money in the long run if there are certain interventions that you can do to be able to ward off higher costs like emergency room or inpatient stays. So you want to be proactive in managing, but at the right level to meet the mandate and expectation. You'll want to partner with hospital and specialty care access. This will be critical to make sure that you're mitigating and managing your costs in a very real way. Looking at your network structure, and you will want to have a very tight dashboard in regards to looking at utilization, any fiscal exposure, so that the board and the public is very aware in regards to where the costs are coming in, the number of people being served, and the team has already been working on an amazing dashboard to really help stay informed through this process as well. So this is just an initial list of things to be evaluating, and I know this will come back to the board in the future for consideration. Next slide. So there are some things, and I think you're already really doing it, but just to highlight in regards to being proactive, which I think is really important. So really planning, scenario modeling, and readiness work is critical. Some counties really haven't started this. You and your team have been going since day one, so you are doing really well in regards to that. Also thinking about certain investments like training and process improvement. When you have this much workload change that will happen operationally for your county staff, really thinking through the training, the systems, the automations are really critical. And so your team has already been doing a lot of that great work and will continue to iterate on that to really improve those various outcomes. Coalition building will be critical, working across various managed care plans hospital providers, community-based organizations. All of those will be critical to make sure the entire community is aware of how San Diego will move forward. As well as the dashboard that I mentioned, really important to have a dashboard so there's no surprises. You're not 6 months in and realize, oh my goodness, the costs have gone up, but you're monitoring and tracking that in real time, or monthly, I would say, maybe not real time, but really looking at those various pieces coming in. And then, of course, sequencing decisions deliberately. I say this because there's so much we don't know yet. It's staying informed, it's being ready to respond, it's ready to have, again, that scenario modeling and planning if this is how we will move. But you want to be careful not to move too fast because there are so many things that are still coming down, and we need to make sure we have all the information before making certain key decisions. In light of that, next slide. The subcommittee is working on a number of deliverables that was requested by that. So we are working on a CalFresh readiness report so that people are informed in regards to how San Diego is ready for the changes on the CalFresh side, as well as a community engagement, and that is what they call work requirements in Medi-Cal. So in Medi-Cal, they could have made it easy and just called it work requirements in both programs. Unfortunately, they didn't. They called it community engagement on the Medi-Cal side, but really it's work requirements. We'll be doing a gap and a strategy assessment. Again, this upfront planning for what will happen on the work requirements in Medi-Cal. We'll also be looking at technology tools to optimize and improve efficiencies for the team here, both for the beneficiary as well as for county staff, which is really important. You want to do both. And then, of course, based on board direction, we will bring back some reassessment options and discussions around the 17,000 obligation. And so that concludes my comments for this morning.
First of all, thank you so much. I would just really appreciate all your help and work on trying to figure out how to navigate this incredible challenge that we're all faced with, I think, across the country, and we're taking really seriously here in San Diego County. I personally have a number of questions, but before we go to public comment, I do want to give my colleagues as well an opportunity for questions. Not to put you on the spot, Supervisor Desmond, but you have consistently asked for more report backs from subcommittees, so here we are. This is what we've been working on, so wanted to give you first crack at any questions you might have.
Appreciate the presentation, the information, and it's a lot to digest, so thanks for the input.
Okay, thank you. Supervisor Geary.
I'll be quick. I know that you guys are way ahead of us. Thank you for the presentation. How is this making our community healthier?
You know, it's a great question. I think that there is a lot of risk here in regards to that, right? You have individuals who potentially could lose coverage for services. They could have chronic diseases or illnesses that make them fall out of that. And so there is a lot of impact to individuals in light of these changes in HR 1. And so that's why the diligence and partnerships will be important, doing everything we can to inform individuals around these changes. And when someone falls out, doing everything we can to move them back into services quickly. And those are the exact strategies that we will be working on. And then on the other side for CalFresh, if someone loses access to food, we know there's a direct correlation to increased emergency room, inpatient, and other health impacts because of that as well. So both of these changes and the fact that they're both happening and in similar timeframes, you know, it does leave the community very vulnerable, but hopefully communities will come together to do everything they can in light of these federal changes to ensure people get back into access when they're eligible and to retain coverage.
And I know your expertise is the health coverage part of this, but how is this saving us money?
Well, it saves the federal government money in a number of ways. In HR 1, they have cut what federal match they are doing in a number of ways, so that's a clean savings for the federal government. Unfortunately, the state then has to make up those savings, and so that is a significant cost for us in the county and at the state level. And then it's really because of coverage losses. I know that it's hard to say, but really the number one thing the CBO at the federal level scored when it comes to work requirements is guaranteeing that people will lose coverage in light of not complying with work requirements. And so a large portion of the score at the federal level will be that. Of course, The state will have an equal amount because they wouldn't be paying for that too. But everyone knows you pay a lot more in the long run if you lose coverage. And so there's a lot of research that shows it actually creates ripple effects outside of Medi-Cal. Someone's going to have to make up for these losses of uncompensated care and coverage. It will potentially spill over into premiums even outside of the Medi-Cal program. And there's a lot of research that shows that. Also, there's a lot of research that shows each administrative churn costs a lot of money. So it'll be interesting to see how the real numbers fall at the end of the day over time. But the big reason why you see such a large scoring of federal savings is really the fact that they are estimating the number of lives that will lose coverage during this time period.
And just to clarify, CBO that's a Congressional Budget Office.
Correct, yes, at the federal level.
So technically, on the front end, the federal government saves money, but ultimately somebody ends up paying it because our emergency departments are impacted, people fall into poverty, our local government is impacted, and ultimately we're funded by our taxpayer dollars, so taxpayers are the ones that ultimately will hit their bottom dollar, their purses, their income.
I think that is a correct assessment.
In one way or another. Yes. Yeah, I would say this bill is cruel, callous, and completely bonkers. So, thank you.
Of course.
Thank you. Not to mention it was led by this president. I'm just putting that on the record. Thank you.
Vice Chair?
JC, thank you so much for being here with us. I hope everyone can see why we thought it was so important for you to be here. And also for your perspective statewide, it's good to hear that, you know, some of the things that we're doing that may still feel like we're sort of in a silo as a county, we're leading on a lot of these issues. So, or just at least the preparation for it, because we're taking it upon ourselves as a local government to try to take care of as many people as we possibly can through the changes that we are about to face. So thank you for that. I just had one question, and it came up as in your presentation as you talked about interventions. So interventions to kind of manage costs during this time. You know, you talked about us monitoring them, but specific interventions, how do you could you go a little bit deeper into what that would look like?
Yeah. So for example, if you have someone who is, has fallen off of coverage, who maybe has a serious mental illness or substance use, that is an example of where under the 17,000 obligation, those are not mandated services that you have to cover, right? But they're also eligible for exemptions under the Medi-Cal work requirements. And so having the behavioral health team immediately working with the eligibility team to identify that as an exemption, get them back on coverage within that 30-day window, right? And being able to manage that within the county system, a really important example of how you're paying attention to the impacts here and then working across all county partners to have an intervention. So that's just one example. Another is, say you have someone with multiple chronic conditions, they have a number of prescriptions, and we know, data shows, if they stop taking those prescriptions, there's a higher chance that they will have an increase or impact on their health. They could go into an emergency room or inpatient stay. That's a lot more costly from a county intervention point of view than to have those medications covered for a gap period, hopefully getting them back into coverage. So those are some examples of where you can use, whether it's primary care or some interventions in a short period of time, hopefully with the goal of getting them back on coverage, hopefully with retro, so then eventually it gets charged to the Medi-Cal program instead of the county. But if you are tracking and managing whether care coordination or pieces that are falling into the indigent care program, it allows you to fastly move to get someone back in coverage if they are eligible and can, or to mitigate and then manage those health factors so you're not paying the more costly services and more the lower cost prescription, primary care, or specialty interventions.
Thank you very much.
Thank you. Supervisor Desmond.
Well, thank you, Madam Chair. Appreciate it. I will comment on, you know, this is like a snapshot in time in this HR1 and HR1 happening and all the repercussions of HR1 with for the federal government, also the state government, you know, having to cut back and stopping free health care for people that are here undocumented. Perhaps if the country had not let in tens of millions of people across the border unvetted, perhaps our benefits would not be in the dire straits that they are in right now. So I know everybody wants to take a look at the little small picture, but the big picture is we let a lot of people come in that are now on benefits and Medicare and Medi-Cal and food and CalFresh. You know, if that hadn't happened, we might not be in the situation we're in today.
Thank you. I have some additional questions. It would be great if we could put the slide back up. They're pretty specific to the presentation. Beginning with the slide that looks at when the different program requirements are going to be implemented and estimates of how many individuals that's going to affect in San Diego County. Okay, thank you. So I think I wanted to just kind of spend a little time on various aspects of this because it's both about like potential impact and also timing. So my first question is around the timing. I think you clearly indicated that there's a lot of the rulemaking has not happened regarding how these new requirements are supposed to be implemented, but the times are actually quite soon. So how is that going to work? Are we going to be required to implement, let's say, October 1 or June 1? That's soon, right? June 1. CalFresh, work requirements for able-bodied adults without dependents. Basically, you can't eat unless you show that you can work. That impacts almost 100,000 people in San Diego County. That has nothing to do with being undocumented. Just noting for my colleague on the left of me, that's 93,500 people. That has to do with work requirements. Do we have the regulations on those yet?
So the CalFresh and Medi-Cal are different. From CalFresh, they didn't have the regulatory requirement that was in HR 1, but there is guidance that is required. I believe, and we'll also defer to my colleague here if there's additional information from county, that the Department of Social Services has released guidance around the June 1st. There's some guidance that is still coming, and there's still some system and automation pieces that are needed on the state side. However, my understanding is there won't be a change to the June 1st go live. And so you may have some systems, depending on what happens at the state level, coming in a little bit later. And there may be guidance that comes later. For example, the state hasn't opined on all pieces tied to those changes. And so it is a hard part about being bottom of the waterfall, for lack of a better description. Starts at the feds then to the states to the counties. Counties are always the last one, unfortunately, to get that information and be able to move on those changes. And so it always makes the first year a little bumpy, is what I would say, in light of big changes that move too quickly. But I will defer if there is any specifics of outstanding items on the CalFresh item in particular.
Thank you. And I'm going to ask about a bunch of these because I'm just trying to wrap my head around it. I think like really specifically, I'll start with that and I'll ask about the others, is, how are we able to, I think that there's a tendency, reasonably, to say, hey, we can't roll out our systems to comply until we know what all the rules are. Mm-hmm. But the problem, of course, is like we have to comply by June 1, even though we don't know what the rules are. So wanted to better understand, and again, I'll ask about each of these specifically, but starting with the one that's now, basically June 1. How are we approaching both complying with these rules and bridging the gap to help folks meet those work requirements basically in 2 months?
So I'll start and then I can turn to my colleagues. So I think the biggest thing is you do have to run on the information you have at any given time. So the state has issued direct guidance. You plan and prepare for the information that has been provided and the guidance that has been provided. I'll give you an example. Historically, on the CalFresh side or SNAP nationwide, attestations have been a big part of eligibility determinations, where you can look at someone through the interview process and you can attest to them being exempt for work requirements, as an example. There are a lot of states who are stopping those attestations, as an example, because they are worried about the error rate, and a lot of times error rates can be tied to that. So they're evaluating those various pieces. State of California, I don't believe, has officially opined on what they're doing, for example, when it comes to attestations within the CalFresh program. So that's an example of where you will need to shift once the state makes a decision. As of right now, it's still attestations, but without an attestation, that means that physical documentation would would have to be provided by that client to be able to then move forward with exempting them from work requirements. And that would be a new process. And so you can do some readiness planning in regards to both of those scenarios, how you would do that, what it would look like. But that's just an example of where current guidance, you plan for that until in which it changes, and then you will have to operationalize those new changes. So if that's helpful as an example, but defer to my other colleagues as well.
Thank you for that question, Chair. Absolutely agree with JC. Her comments also would share that we are in the planning phase. We are training our staff extensively on the new requirements. We are also activating the San Diego Workforce Partnership Hub as a place that we can refer folks for volunteer opportunities or work opportunities when this time comes. And so we're in the planning phase. We have an incident command system that we meet on a weekly basis on this that is across the entire enterprise, including activating our CBOs in order to, again, engage in work requirements and volunteer opportunities, given that we serve many of the same clientele.
Thank you. Okay, kind of moving forward, looking at the full scope Medi-Cal eligibility restrictions, October 1, a different kind of question on this, acknowledging that there are those who would prefer that 75,000 people in California, in San Diego, die on the streets instead of go to the hospital because they don't have satisfactory immigration status, but that is not my view. And I also know that's illegal. So given that we're going to be looking in October 1 at 75,000 people without Medi-Cal, basically, like that's ASAP, if you have an emergency and you don't have Medi-Cal, what happens?
So for this, they would maintain their Medi-Cal emergency coverage. It's just the full scope coverage that is being modified in this particular line item. So if they had an emergency or an inpatient stay, as an example, that would still remain covered for those individuals. It's just any of the other stuff, no preventive services, primary care, specialty care services, prescription services. So you will actually see that those are the things that help avoid an emergency room or inpatient, but
that was kind of what I was trying to better understand. So if you still have emergency coverage, but you can't get preventative care, what costs more? Going to an emergency room or going to a pediatrician to get a prescription for penicillin?
The emergency room and an inpatient are always, well, not maybe always, but typically going to cost more depending on the complexity of the treatment that somebody's in. But yeah, I mean, you always want to avoid emergency room or inpatient stay. Most states only cover the emergency and inpatient. Around 8 or 9 states have that broader coverage that California had. So it's just making that change in regards to it. But overall, you will see people who had full coverage today have less coverage moving forward. So it will be a change for people in San Diego for sure and
who
statewide.
bears that increased cost, right? Like, let's say there was a person who previously cost, $1,000 a year because they went to the doctor for preventative care. And now they don't go for preventative care, so now they're costing $10,000 a year. So now this same individual costs $9,000.
Yeah, so ironically, the federal government and the state of California will bear that cost because they would fall into the emergency room and inpatient. And so they would be paying a higher cost for those because they will have Medi-Cal emergency coverage, which covers those key services, but that's the limitation of those.
And is it a full reimbursement to the hospital, or does the hospital also end up carrying any of the cost? Like, does the Medi-Cal reimbursement fully make the hospitals whole?
Well, I don't know if many hospitals would say they consider Medi-Cal's payment full, but there's also another change that isn't mentioned here, but the federal government announced that moving forward, individuals who are unsatisfactory immigration status cannot be in managed care. They have to be moved to fee-for-service, and so in that case, they would be getting the fee-for-service Medi-Cal reimbursement, and I would say that is probably not going to meet many of the hospital's expectations from that perspective. It varies, of course. I think that's why the part that I mentioned at the beginning of the presentation is so important. A lot of those provider taxes and state-directed payments and various supplemental payments historically help cover some of those pieces when it comes to hospital reimbursement. And with those decreasing on top of then less reimbursement, it's a compounding impact for hospitals.
So just from the hospital's perspective, not from the county's perspective, but from the hospital's perspective, you're saying that they're going to have less state-directed payments that like kind of help compensate for lower Medi-Cal reimbursement rates, and then higher Medi-Cal payment gap because they're now doing emergency care instead of preventive services. So if it's like a, say, I don't know, 30% gap or something in what Medi-Cal reimburses versus the actual cost of service, and it went from $1,000 a year to $10,000 a year, the loss to the hospitals has like pretty significantly increased. Am I understanding this?
I can't speak to that exact scenario, but yes, the amount of uncompensated care is what I would call it for hospitals in light of the full magnitude of these changes will be real.
So how does a hospital, I mean, these are businesses, these are companies that have to stay in business. So now if they have a whole bunch of uncompensated care, how do they stay in business?
You know, historically, prior to the ACA, a lot of states had uncompensated care programs. The federal government used to participate in those uncompensated care programs where you could get an 1115 demonstration, for example, to mitigate some of those losses. We do not know where this administration stands on those types of initiatives that for decades were supported by both Republican and Democratic administrations. We don't know where they stand on those types of things yet, to be honest with you. But without any of those types of relief programs that historically have been in place, then they will see reductions. We do anticipate, and there are estimates out there in regards to hospitals potentially closing in light of these pieces, especially your more vulnerable rural hospitals or critical access hospitals in rural areas are very vulnerable because of the reliance on state-directed payments and provider tax, kind of hospital provider tax pieces across the board. So it's something everyone's watching very closely. There is the Rural Health Transformation Fund that hopefully will be some amount of opportunity for rural hospitals, but it will not be anywhere close to what they are losing in light of the various changes. So we do think hospitals and FQHCs are pretty vulnerable through these changes.
I think what I'm trying to better understand, I mean, obviously, sorry to ask so many questions. I'm so excited to have you here to kind of get us all up to speed. But if there's some kind of big chunk of uncompensated care, and we have a bunch of businesses, you've got to stay in business. I'm trying to better understand what's the impact on all the folks in San Diego County. Say there's 3.3 million people who live here. You know, looking at what you've identified here, there's maybe in the neighborhood of 400,000 whose Medi-Cal eligibility is somehow at risk. Or somehow potentially at risk. So you have 2.9 million people whose Medi-Cal eligibility is not at risk. How does this impact them? Like, will they see, like, how is the hospital going to make up for this kind of uncompensated care? I mean, I'm asking a lot for the folks who,
Sure.
Does this matter to anybody except the 400,000 people?
Well, it should matter to everyone, but at the end of the day, hospitals are going to have hard choices. They may have to reevaluate various lines of business, right, in regards to what's viable. They may have to switch and focus on a different payer mix, right, increasing the amount of commercial or Medicare payment to offset some of the losses. They will have to make hard decisions. We've already seen some start with layoffs in regards to anticipation of different pieces, which then shrinks your workforce and your access availability. We don't really know. I think it's a lot of hypotheticals right now. There's a lot of estimates. So I think people are watching, they're advocating, they're leaning in. But we do know that if all these changes stay with work requirements and there will be a loss of coverage, there will be uncompensated care that will put a lot of fiscal pressure on those hospitals, and I would say FQHCs. And so I think it's going to be important for the state, and everyone nationwide will be paying attention to that. We do know there's another trend is mergers and acquisitions, so locking arms across hospitals we're seeing across the nation, because if you can take your overhead and admin and kind of group it to have some efficiencies, that is another trend that we have been seeing as well. And so those are some of the ways. It's really hard in hypotheticals to kind of say, but those are the things that we're hearing people are exploring in regards to reducing admin overhead, looking at lines of business, some more vulnerable with less cash on hand, the rural, critical access, and others may close.
So looking at potentially some hospitals that are more vulnerable that have a higher Medi-Cal mix,
Yes.
closing. some lines of business either disappearing or being reduced, sort of streamlining, so that we have fewer providers to reduce costs, which makes it kind of harder for everyone to access and get a doctor and get in to see a doctor in a timely way. Those are the three things I'm hearing that you've uplifted.
I think those are fair potential options that hospitals will have to explore, depending on the financial hit for all hospitals is different. But if you have a very large percent of your payer mix being Medi-Cal in California, it will be harder on them than other hospitals that have a more diverse payer mix.
And what lines of provider services tend to be most vulnerable to being cut?
Oh, I do not know that off the top of my head and wouldn't want to inform you in any way without doing more research to give you a better answer to that one, yeah.
And this maybe, Ebony, is for someone in HHSA, but do we have a sense of what hospitals in providers in San Diego County might be the most vulnerable to being shut down or downsized?
I don't have that information. Yeah, I don't. But we can look into that and bring that back to the
I think
subcommittee.
that'd be very helpful. I think it'd be really helpful to know which of our hospitals are most vulnerable. And then finally, again, I understand we don't know what the strategies are that our hospitals are going to employ, but in other places where there's been similar kinds of programs implemented, has there been any like premium increases ever for commercial or private pay to compensate for the reduced revenue from Medi-Cal?
I don't know that off the top of my head. For some perspective, there's only been a few states who have done this through an 1115 demonstration at the federal level. There was many that were approved prior to COVID. During COVID, most of them stopped because you were not allowed to disenroll. So there's not a lot of data that shows that level because we haven't had any state go that long. Georgia's the only state who has the longest tenure with work requirements. They saw significant coverage loss from their initial program, but I don't have any information in regards to the impact on the larger population. Theirs is a little different. The way Georgia does their work requirements, at least historically, it will change. They'll have to comply with HR1 come the timeline, is they did it for expansion coming in. So it's different than California, who already has a very large expansion population enrolled and then losing coverage. The way Georgia did it was when they expanded their ACA population, they did it with the provision of only if you met the work requirement piece. So it's not comparable in my opinion. So I don't know if we have that data to be able to demonstrate that. That comment I made is more on just historically, the amount churn can impact premiums is very real because of the disruption of what we talked about on various pieces, and that is why you want churn to always be less. That's why all states focus on reducing churn, because any loss of coverage and then coming back into coverage disrupts premiums historically. But I can't speak in particular for work requirements. Unfortunately, we don't have enough data with something long enough to better understand those types of impacts.
Okay, thank you. So many questions. Now, finally, I'm going to let you go soon, but we don't get you much, so just so appreciative of you being here. If you could go back to our slide on, it's kind of towards the end of like what we got to work on, next steps, basically. I think it might have even been the last slide.
Yeah. I think one more.
No. Yes, exactly. Just, I think it would be helpful, I mean, obviously I'm a little bit more involved in this piece, but just for the public, so like situational awareness, to better understand what these pieces are and what they mean.
Sure. So the CalFresh Readiness Report will have a full overview of impacted populations. It will go through the various strategies that the county has been taking, whether it's a communication plan, it will identify your largest risks, even continued risks, and opportunities to mitigate those, or at least inform the board around any of those ongoing pieces. It will talk about operational impacts, the amount of staffing impacts, the workflow impacts. It will also go over system opportunities, whether already implemented based on the team's assessment to automate and move things through the system, or future investments that could be considered to improve the operational efficiency for that, or to improve, reduce churn as an example. It will also include the measures and metrics that the county is planning to evaluate in that dashboard we were talking about in order to monitor those pieces. So those are the components that would be in the CalFresh, essentially giving you a playbook for population impact, potential fiscal risk. Again, that's still evolving because of some state stuff, and then operational system impacts and metrics that they will be monitoring to give you, a good understanding. I would say San Diego's doing a really great job here. The team here is actually really significantly leaning in regards to these pieces. So that's the CalFresh Readiness Report. The community engagement gap and strategy assessment here, that's where we will be doing a similar look. What are our biggest risks? Looking at the populations. Are there at-risk populations? There should be more engagement, leaning in. Who are our partners for managing that? What is the interaction with the 17,000 obligation? That will be really assessing what do we currently have, what potential things may be needed to address that population. Given the significant change, there will also be a large community outreach part of that will come in there. And so that is the community engagement gap and strategy assessment, really outlining how San Diego plans to do everything they can to reduce that coverage loss that we were talking about. And then the technology tools to optimize, that's really looking at, are there opportunities in technology, whether through efficiencies and automations in your existing systems or programs, or AI as an example, making sure that staff are working at the top of their ability and not wasting a lot of time on administrative tasks that can be automated pieces. So it's always important to do with this big of an operational change is to assess those potential opportunities. I would also say there's a lot of states thinking through technology opportunities around the beneficiary impact too. How do you keep them informed? How do you keep them reducing the administrative friction? With this type of work, you're going to see a lot of people fall out of super wonky term, but ex parte, and that's where the state is responsible for scanning any and all data and information they have to say this person's eligible or compliant with work requirements. If the state doesn't have access to income or their education or community service hours, and they say, oh, now you need to turn in some documents, there's a lot of things you can explore in regards to making that easier for individuals to gather that information and get it back to the county in order to do that. There's some that are looking at quick automating of the document to scan it for compliance as an example, or loading those things. So I do think it's important for San Diego to at least evaluate your options and pieces. Some may not be viable or supported here, but it's important to do that in light of the significant amount of administrative friction that happens once it goes to the beneficiary to respond documentation. And then the last one is really the previous slide that we had, really doing a full reassessment of what is your current policy, and then some options for how to look at both eligibility, what benefits you cover, exploring tiers, cost sharing, a variety of different pieces that network. This will be pretty comprehensive to just evaluate how it works. It's been a long time since San Diego had to run an indigent care program at the potential size this could be. And so we'll want to be thoughtful in regards to the fiscal impact each of those various scenarios could bring and how to kind of balance that for the county itself as well.
Thank you. Thank you so much. Thank you for all your work. I'm just really grateful that we have your support. I'm kind of trying to figure out how to move this forward. Question for Ebony. Has there been any kind of press release or briefing sent out to press around kind of this update?
Thank you for that question. Not specific to this item, but I'll defer to Liz. It sounds like there may be some plans here.
We've done some social media to push out this information out to the public, and we've done some county news center articles as well regarding this information, and we have a very robust communication plan, but always open for more suggestions.
I get asked by reporters a lot, and so they don't seem to have this information. So it seems like they should have it, because I get probably 3 requests a day to better understand this. So there's definitely feels like there's kind of a media, like a reporter appetite to better understand these moving parts. Yeah.
We'll work with your office to do that.
So
Thank you.
Maybe talk to Tammy?
Yep, we'll do.
Thank you. Thank you all. Any other comments? Any other comments from my board colleagues? Okay, we'll go to public comment.
Thank you, Chair Lawson-Remer. We have 14 requests to speak on this item, 4 in person and 10 requesting to speak by phone. Also note for the record that we received 1 e-comment in opposition. For any individuals that requested to speak on item 26 by phone, please dial into the conference line using the instructions that were provided to you. We'll begin with the in-person speakers. As your name is called, please come forward and stand on the arrows until it is your turn to speak at the podium. Because there are 10 or more speakers on this item, you will have 1 minute to address the board. And I'll ask you to begin by stating your name for the audio record. I'd like to invite forward the individuals in person: Catherine Rhodes, Cesar Javier, Jacob Duarte, and allegedly Audra. If I've called your name, please come forward.
Hi, thank you very much for your report. That was lovely. My name's Catherine Rhodes. My favorite document, periodic financial reports, love it. You still have, you have $16 billion in the fund balance. In the Mental Health Service Act, you have you have 5 million in fund balance, but you have 245 million in cash because it's a multi-year thing. So I would like you to allow the severely mentally ill people to use that money to work or whatever they need to do. So that's cash for you. That would help with this program. So if you could analyze it, and if you need help, you could talk to me. Also, the ARPA fund balance, that needs to be spent by the end of the year, and there's still $14.8 million in the federal funds from COVID-19 left over that have to be spent, that could be used for the poor and stuff like that. And then the general fund still has $929 million in fund balance and cash. So there's cash in the general fund. And all of this is in the periodic financial report that I just pulled up today. My timing didn't start. I don't know what it is. Thank you. I'm almost done here. So there's a lot of money sitting around for years, and the county has finally been using some of the money, which is great, but there's still some money that could be used for the poor. Thank you.
Thank you. Next speaker, please.
Good morning. Mayor Jones of San Marcos led the prayer before the council meeting last night. We reached everyone in San Diego, elected officials, fellow citizens like us in our community. We have advisory board. We have been attending health advisory board. And you know what? Did any advice reach you regarding health and survival of San Diegans? It will not reach you. Why? Because they are loyal to you and not to the Constitution. Our niece sacrificed so they could protect us. Are you protecting us?
Thank you. Next speaker, please.
2 minutes. Thank you.
Talk about the business of healthcare. You guys are bonkers. I'd like to say that Jezebels are terrorists. I don't recall Jim saying he wanted 75,000 people to die on the streets, but maybe those are the subtitles that you read. It's interesting because FAFO, he is correct. You guys decided to put those people on there, therefore taking it from people in the community because people in our community lost their benefits and these people got them. And that's not fair. That's like saying if there are 2 people on the street, you're going to help the undocumented person over the person in our community because that's what's been happening. And now people are suffering the consequence of it. And unfortunately, you guys encourage dependence upon you. And if instead we encourage like being healthy and different things, this isn't health care, it's sick care. It's to make people just constantly come back. I was on 100 pills a day and paralyzed from a spinal tap because I have MS. And it's like, so it's not health care. It actually makes you sick, and we should be teaching people to become independent of you guys.
Thank you. We'll now hear from those that requested to speak by phone. We'll start with our first caller.
Good morning. My name is Terry Ann Skelly. Heart disease remains the leading cause of death in the United States and Mexico, and the second leading cause of death here in San Diego County. And as the county public health officer advised, and I quote, make small adjustments to lifestyle to improve our health, decreasing the likelihood of substance abuse and mental health struggles, like quitting smoking and vaping. The Journal of American Heart Association released this statement, and I quote, cannabis use poses significant heart health risks. It increased the likelihood of heart attack, stroke, and heart failure, even in young, healthy individuals, by accelerating heart rate and raising blood pressure, straining their arteries. What can policymakers do to decrease heart disease in their residents? Create policies that decrease exposure to secondhand and third-hand marijuana and tobacco, smoke and vapor, like smoke-free public places and complexes, and reduce exposure to billboards, promotions, and tobacco and marijuana storefronts presence here in our county.
Thank you. Hear from the next caller.
Howard, can you guys hear me?
Yes. Yes, please.
Okay. Thanks a lot. Hey, I'm Howard. I'm for mass deportation, like quickly. And I think you guys are aiding and abetting the illegal aliens. I think you should go up on federal charges for putting these things in. We got to get rid of these guys, put San Diegans first, wherever you're from. They're even shutting down the banking system for illegals. They're going to make it hard for guys to get banking in the United States if you're not a citizen. So they're going at different angles. The feds have the numbers of those 75,000 who live in San Diego County that are doing benefits that are illegal. They know where they live. They just got to click a button. And these guys got to get denied service, put them on a trolley heading to Tijuana or wherever, offer free trolley rides heading south on the Blue Line. Now, that'll be kind of a good advertisement to put on. But whatever country they're from, they got.
Thank you. Hear from the next caller.
We're so busy playing all these political games, we're not really realizing what is happening. By all means, go ahead and further the problem. Don't address the vote by mail issue, where basically anyone could go ahead and sell your signature to someone willing to commit voter fraud. The Registrar of Voters will go ahead and cover that up. NVRA will go ahead and protect the people committing voter fraud. And Damon would do everything in his power to make sure that the people committing voter fraud is not prosecuted. Isn't that correct, Damon? You understand exactly what the NVRA protects. It protects people willing to commit voter fraud in order to steal someone's ballot. All I need to do is go ahead and find out who checked out registration cards, find out how many times a person happened to re-register on another election based off of who they want to go ahead and replace. All the transient, all the homeless voters, you know, the people, the citizens.
Thank you. For the record, the speaker was Justin Castro. Hear from the next caller.
All aboard. Good question. It's good to be prepared. In fact, I wish you had similar presentations starting in late 2024. The writing was on the wall back then, for sure. If you're looking at medical savings, there's a lot to be said for homeopathic and natural cures. They work, they're less expensive than big pharma schemes and patent medicines and one-size-fits-all thinking. They have less side effects, even though they're a bit slower. But, you know, they work, as I say. And that's kind of like ventilation for COVID. Instead of locking healthy people up in with sick people during COVID. would save a lot of money, maybe lives too. And if you are able to use some of the opioid settlement money.
Now hear from the next caller.
Good morning, Board of Supervisors. Ann Riddle here. I see this as an opportunity to have a better understanding of the needs of our county residents. As the report stated, you would be exempted from the work requirement of H.R. 1 if you were receiving substance abuse treatment or mental health assistance. So if someone was going to be denied their CalFresh or Medi-Cal benefits, and they were experiencing these problems, they could go into our county programs and be exempted. So this might be a way to help them receive the services they need. After all we're asking is that healthy people work. It doesn't, on the face of it, seem to be a problem, but it could certainly be an opportunity. And while we're at it here at the county, we could examine our policies to see what encourages healthy living. And as the previous speaker pointed out, our county's newsletter puts out excellent information regarding what.
Hear from the next caller.
It's truth. J.C. Cooper had zero answers on how the county could pay for these self-destructive ideas. That's because J.C. works for Health Management Associates located in corrupt Sacramento. She's a former corrupt state Medicaid director who designed the CalAIM program, which gave taxpayer-funded care to incarcerated criminals and illegal aliens. J.C. is the Newscomb-appointed minion who ran a failing state system and has zero health qualifications, only a meaningless political science degree, and that's exactly the type of politico Tara loves to use. Tara can even be transparent. Did she tell Joel to look up J.C. Cooper to find the transgender that stole medals from women? Tara forced Joel, who still idiotically voted yes to backroom deals with J.C. after being disrespected, to write a very accurate op-ed entitled, "Good Government Operates in the Sunshine." Well, too bad we've got cockroaches on this board. As Lou Cummins said, if Tara the Terror and her henchwomen are sneakily pushing secrecy in the subcommittee policy procedures, that alone should be a big-time red flag that they oppose their constituents' right to full disclosure, which is the polar.
Thank you. Hear from the next caller.
Gosh, I wish we had 2 minutes. Okay, Consola here. So things will be getting even more chaotic in the future, guaranteed, so buckle up, not only because of federal cuts and changes, but also because of direction tied to the United Nations agenda for the 21st century. Our government has created a system where so many have become dependent on it, it's made its bed. So funded by our tax dollars, that bed is. And now it's getting critical because this county will no longer have that federal cushion to fall back on. But here's the silver lining, okay? This is why I wanted 2 minutes. Things can shift instantly, and you sitting there temporarily, who are temporarily in charge, can actually use this moment for good. You can co-create true beneficial programs with our local farmers, paying them instead of corporations for real food, real medicine, to teach the people who've become dependent on government how to actually feed themselves. That's real sustainability. In the long run, it saves the county tons of money and contributes to real growth. That's a win-win. But I know that's not the business model of the government.
Hear from the final caller.
Good morning. My name is Jack Daly, Director of Health Policy at the Legal Aid Society of San Diego, the county's largest nonprofit civil legal service provider, offering comments in support of this current item. For over 25 years, Legal Aid's Consumer Center for Health Education and Advocacy has provided legal services to ensure that San Diegans can obtain and maintain health care coverage through programs such as Medi-Cal, Cover California, and County Medical Services. Legal Aid applauds the Board of Supervisors' efforts to develop and implement a coordinated response to the numerous state and federal policy changes that will cause San Diegans to lose Medi-Cal coverage and disrupt needed medical care and treatment. We appreciate JC's comprehensive presentation and recognition that a multifaceted approach must be pursued, including Medi-Cal retention efforts, revision and improvement of county medical services, development of effective safety net bridge programs, and other efforts to protect San Diegans. We at Legal Aid look forward to engaging meaningfully in a robust stakeholder process for further debate.
Thank you. Chair Lawson-Remer, that concludes public comment on this item.
Okay, thank you very much. Is this just an accept or do we need a motion? Okay, great. We're happy to accept the report. Thank you so much. So we'll now move on to item 27, and I'll turn to my colleague, Vice Chair Montgomery-Steppe, to introduce this item.
Thank you so much, Chair. I believe we have a presentation. So we can just begin with the presentation, if that's okay. Thank you.
Good morning, Chair Lawson-Remer and members of the board. On November 4th, 2025, the board directed staff to explore options for establishing a safety net bridge program to address anticipated gaps in services for residents who are disenrolled from benefit programs due to changes to CalFresh and Medi-Cal eligibility requirements resulting from H.R. 1. In response to the board's direction, staff conducted a feasibility analysis and shared the preliminary results with the board in a February 2026 memorandum. I am joined today by Jamie Beam, Director of Medical Care Services, and Eden Bruckman, Chief Sustainability Officer with the Office of Sustainability and Environmental Justice, who will share the options developed as part of the final report. I will now turn it over to Jamie Beam, who will share more information on the safety net bridge options. Jamie?
Thank you, Dr. Hernandez, and good morning. The vision for the Safety Net Bridge program, as directed by the board, was to provide no-cost primary care with access to social services, medications, and fresh food using a one-stop approach for people who may lose Medi-Cal coverage due to federal work requirements under H.R. 1. On March 3rd, 2026, the board directed staff to evaluate and recommend updates to county medical services, the state-required indigent care program serving adults who do not qualify for Medi-Cal. The Safety Net Bridge program is distinct from county medical services as it's designed to address short-term needs of individuals experiencing a temporary gap in Medi-Cal coverage as a result of H.R. 1. Although the two programs differ in scope and population, the Safety Net Bridge program will need to align with any future changes to the county's larger strategy for indigent care. For the Safety Net Bridge feasibility analysis, county staff analyzed the potential impacts of eligibility requirements, assessed existing resources, and engaged with community partners to develop options for people who may lose access to primary care, medications, and food assistance. A critical component of the feasibility analysis involved identifying communities within the county likely to have the highest anticipated impact from federal work requirement policies. Locally, there are approximately 314,000 people who will be subject to the Medi-Cal work requirements, and estimates show that as many as 100,000 people could temporarily or permanently lose access to coverage. To drill down further on who may encounter temporary gaps in care for ongoing health needs and where they reside, we narrowed our focus to Medi-Cal enrollment data for 40 to 64-year-olds subject to work requirements in each zip code. This graph shows the 13 communities with the highest volume of individuals who may lose Medi-Cal coverage and have ongoing health needs. In addition to analyzing the overall volume, we identified which communities experience more concentrated effects of H.R. 1. This map displays the high-volume zip codes from the prior slide overlaid with the Social Vulnerability Index. The Social Vulnerability Index is a place-based tool that uses demographic and socioeconomic data to evaluate factors such as poverty and lack of access to transportation and housing. The highlighted communities shown in dark green on this map are those that are particularly vulnerable to the impacts of H.R. 1 and may benefit from a safety net bridge program. Our primary goal will be to proactively ensure all individuals across the region who are eligible for Medi-Cal under the new H.R. 1 rules will maintain their access to Medi-Cal. The Safety Net Bridge program will help mitigate the impact for those that do temporarily lose coverage across the county. After analyzing the policy impacts, assessing existing resources, and discussion with community partners, staff developed 6 options for transitional access clinics as envisioned in the November 9th board direction. Each of these options includes primary care, access to medications and food, enrollment assistance from our self-sufficiency team, and care navigators. The proposed options are not intended to be a one-size-fits-all approach. Each of the 6 options are scalable and intended to be customized and paired with other options based on the individual community needs and resources. Option 1 proposes telehealth as a low-barrier way to provide care either with county staff or volunteer clinicians or by supporting existing telehealth capacity at community health centers. It has minimal facility requirements, but requires investment in telehealth platforms and alternate strategies to deliver medication and food. Option 2 focuses on strengthening existing free clinic networks by partnering to add more days and times to serve people. Same-day medication, food, and Medi-Cal enrollment would be added services to the existing network that exists. Option 3 would bring mobile medical units for primary care to our county LiveWell centers. This could be either county-run or in partnership with local community health centers. This option can be launched quickly and would require staff and same-day access to medication and food. Option 4 includes the establishment of permanent county-operated primary care clinics within the LiveWell centers. This option would require the most significant upfront infrastructure investment, as we do not currently provide primary care at any of our sites. The 5th option builds on the success of existing community health fair models that utilize mobile medical units to expand them to more sites. This option could be deployed quickly and supports meeting people where they are. Option 6 involves contracting with community health centers for medical care and linkage to social services to help offset costs for visits, medication, and food support to ensure individuals stay connected to their existing primary and specialty care providers while ensuring additional costs and copays are not passed on to patients. Further details, including cost ranges and workforce needs for each of these options, are provided in the full Safety Net Bridge feasibility analysis report. The report also includes recommendations for providing access to food, which Eden Brookman, Chief Sustainability Officer, will now discuss. Eden?
Thank you, Jamie. The report also outlines a menu of food access options that can be paired with any of the clinic options that Jamie described or implemented separately. Food access options complement our ongoing collaboration with local food banks and pantries and correlate with several strategies that departments across the county organization are currently developing as part of the Food Justice Community Action Plan, or FJCAP. The FJCAP includes 11 board-directed actions that the county can take in the near term to improve food access and reduce food insecurity. FJCAP strategies will directly inform and support implementation of the Safety Net Bridge program. Our current schedule is for draft strategies to be shared with the board late April and final strategies in summer 2026. Details will be provided to demonstrate how each of the following may be addressed. As it relates to activities at county facilities, staff are exploring 3 options. First is the potential to add cold storage capacity, such as refrigerated storage space, to temporarily hold food for pickup and distribution. A second option is to designate or retrofit space for non-perishable food storage, allowing community partners to hold and distribute shelf-stable food. Third is to expand existing food distribution events to increase the number of households served. Other approaches include purchasing or leasing a refrigerated truck for county use to support mobile food distribution and food recovery, or supporting the purchase or lease of a refrigerated truck for exclusive use by local partners. The last option being explored through the Safety Net Bridge program is to help local partners expand non-perishable food storage or cold storage capacity at their own locations. There will be future fiscal impacts and resources needed. Food storage or distribution at county facilities may also require specific food handling, safety, and security measures and credentials, and would likely impact space and staffing for core services. Today's action requests the board to receive the Safety Net Bridge Feasibility Analysis Report and to authorize development of an implementation plan for a pilot and return to the board within 180 days for authorization and requested funding. Thank you for the opportunity to present today. This concludes our presentation, and staff are available for questions.
Thank you. Very helpful and a very strong compliment to our prior presentations. That was great. And I just really want to thank the Vice Chair for your vision and leadership on driving this forward and acknowledging that no matter how hard we try to prepare, we're going to be behind, because we can't help but be behind because we don't even know what the rules and regs are. So I'm glad that we have underway a bridge program. So this is very, just very important for our region. So do you want to say anything about this before we go to public comment?
You know, I think we can go to public comment and then I'll.
Okay, great. Okay.
Thank you, Chair Lawson-Remer. We have 20 requests to speak on this item, 12 in person and 8 requesting to speak by phone. Also note for the record that we received 2 e-comments, 1 in support and 1 neutral. For any individuals that requested to speak on item 27, please dial into the conference line using the instructions that were provided to you. We'll begin with the in-person speakers. As your name is called, please come forward and stand on the arrows until it is your turn to speak at the podium. Because there are 10 or more speakers on this item, you'll have 1 minute to address the board, and I'll ask you to begin by stating your name for the audio record. I'll be calling you in groups of 3, so I'll ask you to please listen for your name. I'd like to first invite forward the first 3 individuals, Catherine Rhodes, Cesar Javier, and Jacob Duarte. If I've called your name, please come forward.
Hi, this is Catherine Rhodes. I have the solution for you. This is a 1992 agreement for cooperation between the County of San Diego and the Redevelopment Agency. There's $30 million that come in annually every year that is supposed to be used for the poor. Right now, the county, when I went to the county before back in 2010, they said, we're just taking that money and putting it into the general fund when it's supposed to be going toward directed things. And the directed things include, and it's 14% of the tax increment of different areas in downtown. And I could give you all this information, I have it all. So anyway, it's for health, welfare, facilities, and programs. That would be you, that would be your project. It's for children, service, facilities, and programs, alcohol and drug, mental health, people who coming out of prison who will need your help. But the thing is, this money has to be spent within the city of San Diego. And I've talked to Monk, when you were on the city council, Ms. Montgomery Stepp, I talked to you about this, but I don't think anybody understands.
Thank you. Thank you. Your time is up. Next speaker, please.
We are ready to protect our elected officials. Are you ready to protect us? We chronicled, we amplified to the advisory board, please, let's not solve the problem next year, but now. Let us focus on uprooting the causes of these health risks and health deadly impact. It's here. Ma'am Rimmer, we will help you to step down because you're not thinking. Please think for us, all of you elected officials, especially Ma'am Stipp, who came from the city elected officials before and after and during, and even now. We saw you clapping your hands in the affordable housing construction accomplishment. You have nothing to do there. Thank you. Thank you. Help us.
Thank you. Thank you. Thank you. As the next speaker is coming forward, I'll invite 3 additional speakers. Lorena Slomanson, allegedly Audra, and Michelle Surakanova. If I've called your name, please come forward.
Good morning. My name is Jacob Duarte, representing the San Diego LGBT Community Center. I'm here in strong support of this item. The Safety Net Bridge program is exactly the kind of proactive, compassionate governance that San Diego residents deserve. We're looking at over 100,000 people in this county who are at risk of losing their Medi-Cal coverage. Many of them are people we serve directly, immigrants, low-income families, and many other people of marginalized groups that face significant barriers to health care. For many of them, losing coverage is not inconvenient, it's a crisis. What this board is considering today is a bridge, not a permanent fix to every problem, but a commitment to not leaving people behind while the dust settles on federal and state policy changes. That matters enormously. The community showed up for this process. Hundreds of residents attended input sessions across every supervisorial district. They told you what they need. This program is the county's answer to that. We urge the board to approve of this item and move forward with the pilot. Thank you.
Thank you. Next speaker, please. If I've called your name, if you could please line up on the arrows. Thank you.
Greetings. My name is Lorena Slowenson from the Legal Aid Society of San Diego, which is our county's largest provider of free legal services, offering comments in support of this item number 27. Legal Aid applauds the Board of Supervisors' efforts to develop and implement a coordinated response to the numerous state and federal policy changes that will cause San Diegans to lose Medi-Cal coverage and disrupt needed medical care and treatment. We urge the Board of Supervisors and county staff to develop comprehensive and cohesive solutions to these challenges grounded in robust stakeholder engagement. Proposed solutions should first prioritize targeted outreach to individuals at risk of losing Medi-Cal coverage and then delivering supports and services that help maintain their coverage. When San Diegans lose their Medi-Cal, proposed solutions should prioritize engagement of services to help people quickly reinstate their coverage. The proposed Safety Net Bridge program must also be developed in concert with efforts to revive the CMS program as their last potentially best option for ensuring access to health care coverage and services. Thank you.
Thank you. Next speaker, please.
Hello, Chair and members of the board. My name is Michelle Sorokinova. I'm with Neighborhood Healthcare, speaking on item 27. Neighborhood Healthcare is committed to helping residents impacted by federal changes stay connected to care. Our health centers are already trusted medical homes for many patients at risk of losing Medi-Cal. We have eligibility workers. We offer same-day appointments. Last year, we cared for over 104,000 patients with 613 visits. We have 1,600 staff members who provide everything from primary care to specialty services. Our point being is using existing clinics is the best way to avoid confusion, prevent fragmented care, and reduce unnecessary costs to taxpayers. We're asking the board to focus the pilot on option 1B and option 6 with rural communities in mind. These options are faster, more cost-effective, and ready to implement because CHCs, like neighborhood healthcare, we already have the staff, we have the clinics and space available. Thank you.
Thank you. So next speaker is coming forward. I'll invite 3 additional speakers: Amanda Berry, Alejandra Perez, and Anthony White.
Man, if we didn't live in an inverted world and it wasn't a business to make people sick and then take care of them, it would be nice. And this is an opportunity to turn away from that kind of a system, because you guys encourage people to take shots that kill them and that maim them and that make them very sick. So it's really hard to sit up here and think that you guys are doing anything that's going to be beneficial to the people when you refuse to acknowledge that. And, when I was, living in the matrix and believing that the healthcare system was actually going to make me better, and they kept putting me on more and more and more and more pills because it's like the more you take, the more you have to take because there's some other side effect that comes in. And people used to tell me, get off your meds and you'll feel better. And I thought they were crazy because I was like, no way, these are helping. And it actually wasn't, and I haven't felt better. I still have issues, but I still had them when I had the pills. And if I were still taking 100 pills a day, I would be dead. So this isn't health care, it's death care, and it's a business, and that's egregious.
Thank you. Next speaker, please.
Good morning. My name is Amanda Berry, speaking on behalf of Health Center Partners of Southern California, representing 17 community health centers. We are facing a coverage and care disruption crisis, and we are already seeing declines in Medi-Cal enrollment. The county's priority needs to be preserving and maintaining coverage through increased outreach and eligibility. The patients most at risk of losing coverage are community health center patients, many of whom will lose Medi-Cal due to paperwork barriers. However, they will not lose their medical home. They will continue to be our patients. Health centers have the capacity to take new patients, provide wraparound care, 340B discounted drugs, and referrals to community resources. Based on the county's feasibility analysis, the fastest and most cost-effective path forward to bridge any gaps is to work with existing safety net providers, not create duplicative ones. We respectfully urge the board today to focus the Safety Net Bridge program on the pilot outlined in option 1B and option 6 in partnership with community health centers to ensure access to telehealth and in-person primary care. Thank you for your attention.
Thank you. Next speaker, please.
Good morning, chairs and member of the board. My name is Alejandra Perez, and I'm here on behalf of San Isidro Health, one of San Diego County's most trusted safety net providers. We provide care all across the county, from Vista down south to San Isidro, out east to Julian and Campo as well, delivering high-quality, compassionate care, dental and behavioral health care services to over 162,000 patients across the county. And with a dedicated economic engine of over 3,000 staff who are from the community as well, in which 77% of those identify as female as well. So from our beginnings, we serve patients from across the county, and these are hardworking families in the region that really rely on consistent, responsive, and deeply rooted in the communities that we serve. Many of the individuals that are now at risk of losing Medi-Cal coverage are our longtime partners and patients. While their eligibility may lapse, their medical home does not. We remain committed to the continuity of care, especially for those most vulnerable.
Thank you. As the next speaker is coming forward, I'll invite 3 additional speakers: Heather Baston, Paul Heggie, and Bob Kamensky.
Good morning. My name is Anthony White, and I'm speaking on behalf of True Care Community Health Center, serving 70,000 patients across 27 sites in County Districts 2, 3, and 5. We want to applaud the county for the proactive steps you're taking to address the negative impacts of H.R. 1. We urge the county not to spend resources on building a parallel clinic infrastructure that duplicates care already provided. Health centers currently operate approximately 200 service locations across San Diego County, and FQHCs see the patients that are most likely to be impacted in the presentation that Ms. Cooper provided earlier. We're already seeing the negative effects, and patients are losing coverage to struggle to stay on Medi-Cal and may need significant help navigating complex eligibility and renewal requirements. But these are not new patients. They are known to us, and they'll continue to come to see us. If the county has resources to invest, those funds should be directed towards eligibility and enrollment so that folks stay on Medi-Cal in the beginning and not have to address their needs once they fall off. Thank you.
Thank you. Next speaker, please.
Hello and good morning, supervisors. My name is Heather Baston, and I'm a proud SEI Local 221 member and a county employee. I have worked at Behavioral Health Services, Adult Case Management for about 1.5 years. The work my colleagues and I do is absolutely vital for the community because as public mental health program, we are often the last support for those suffering, often alone with severe mental illness and co-occurring conditions. We must support a safety net because those we serve are already facing a crisis, the loss of their benefits such as Medi-Cal and CalFresh due to federal changes and redeterminations. Today, we ask you to take action so that our community members can continue to access care. By implementing a safety net bridge program, we can ensure our clients don't lose access to much needed care before their conditions worsen and they come back needing more than they did before. No one deserves to fall through the cracks. Again, we ask you to take action on this matter. Thank you.
Thank you. Before the next speaker begins, I'll call the final speaker in person, Aaron Brennan Burke.
Thank you, Madam Chair and Supervisors. I'm Paul Heggie, CEO of the San Diego County Medical Society, made up of over 4,600 practicing physicians, trainees, and retired physicians. The San Diego healthcare community has long prided ourselves on the collaborative relationship we share. Clinics partner with hospital systems. Competing system chief medical officers meet during times of crisis to share best practices. Partnerships exist across our sector. Health centers are established primary care medical homes with trusted relationships in the most impacted communities. Using existing clinics avoids confusion, duplication, and fragmentation of care. For these reasons, I strongly encourage you to advance option 1B and 6 in the proposed safety net bridge program. Thank you.
Thank you. Next speaker.
Good morning. My name is Bob Kaminsky. I am the CEO of Feeding San Diego. We are a leading hunger relief organization in San Diego County. In May of 2025, we were feeding on average 155,000 households a month. For the past 4 months, it has risen to over 220,000 households a month. We provide a bridge, not a continuous flow of food, to people who are facing food insecurity. Food insecurity, coupled with housing, coupled with health care, create a three-legged stool for a family. Any one of those legs that gets cut, they fall off. We ask for you, consider item 27, the bridge, and help fellow San Diegans. Thank you.
Thank you. Next speaker.
Good morning. My name is Erin Brennenberg on behalf of Family Health Centers of San Diego. We appreciate the opportunity to respond to this item. Our organization serves more than 227,000 patients each year, of whom 91% are low income and 29% are uninsured. At over 90 sites across San Diego County, our staff provide comprehensive primary care, behavioral health, dental, vision, specialty, and supportive services, including enrollment assistance. As a federally qualified health center, our commitment is to provide high-quality care regardless of patients' coverage status or ability to pay. To mitigate the harms of H.R. 1 and reduce uncompensated care, we support option 1B and option 6. Partnering with community health centers keeps patients connected to their primary care medical homes, avoids creating duplicative systems that fragment care, mitigates potential liability, and ensures that limited resources are directed to where they're needed most. Thank you.
Thank you. We'll now hear from the individuals that requested to speak by phone. We will begin with our first caller.
Hey, asshole. Curiosity. As you eliminate more and more jobs and more people are going to need these assistance, where are you going to come up with that money? I mean, if you go ahead and give the tech industry ability to go ahead and make things cheaper for you personally, where are you going to get the money to help out the people that you're going to displace? Do you really care about the low-income people? Or are you just trying to bridge this until, 2 more years are up, and then you gain full control again? I mean, not you. I mean, the people willing to commit voter fraud. You know, these organizations that want more and more money from the county and the government. But as all these jobs get eliminated, your money goes down. I mean, we saw that with Assembly Bill 5, right? You guys wanted more tax money. What ended up happening in response was a lot of people left California. A lot of big businesses leave California, which means that you're more dependent on the federal government. What I say is just recycle our plastic.
All about. You probably should have also thought of this one in late 2024. Use your imagination. The writing was on the wall back then. Recommendation items like expanded medical could and should have been done years ago. Some of these things like pursuing grant opportunities or expanding partnerships on food security are already being done. And I do hope you consider saving money by using homeopathic and natural cures. And I not from playing recommendation 3B, that is.
Thank you. We'll hear from the next caller.
Hello, my name is Ron Stark. I'm the president of San Diego Veterans Coalition. I want to take time to encourage any opportunity to provide extended food and nutrition benefits to veterans and their families. Many E1 through E4 active duty are eligible for these food requirements, but those who leave the military, especially those junior, regardless of age, we have junior enlisted who are veterans in this county and their families of all ages. Right now, Courage to Call, Food Banks, Feeding San Diego, Support the Enlisted Project, STEP, Veterans Association of North County, local community, faith-based civic organization, food pantries are stressed right now and operating at capacity. Any assistance that can help provide nutrition for those in San Diego County is encouraged. Thank you.
Thank you. We'll hear from the next caller.
This is Ron Stark, president of San Diego Veterans Coalition.
The woman, a previous speaker who mentioned a decline in outreach, I'm so happy there's a decline. To me, that's just a sign that people are waking up to the fraud of the medical care racket. It's a disgusting system, and it solely relies on return customers, and there's no incentive for actually healing a patient. And yeah, that's the Rockefeller motto. Can you hear me?
Yes, please go ahead.
Hello.
Yes, please.
Okay, that's the Rockefeller motto. And also, you know, to continue on the last item, but I mean, this item and the last item are basically the same thing. It's just, you know, at this point, you guys might want to look at yourselves as parents, even if you don't have children. A good parent raises their child to become independent, not to come back for every problem they have, not to stay dependent forever. But that's not the system. It enables dependency. It creates vulnerability. It has people sick. And instead of...
Thank you. We'll hear from the next caller.
Good morning, supervisors. My name is Noah Yik, and I'm a researcher and policy advocate with the Center on Policy Initiatives. Healthcare and food are human rights. Things people need to survive, to care for their families, and to live with dignity. Yet right now, hundreds of thousands of San Diegans are at risk of losing both. The federal administration is choosing to let people starve and remove access to care. We urge you to vote yes on item 12. This bridge program is a step we must take to support San Diegans who lose access to food or healthcare benefits because of state or federal policy shifts. The question before us is simple. Will we allow cruel decisions in Washington to harm San Diegans, or will we step up to protect our neighbors? The Safety Net Bridge program is how we live our values. It says that in San Diego County, no one should go hungry, no one should go without care, and we take care of each other. We urge you to vote yes and commit to seeing this process through. Thank you.
Thank you. We'll hear from the final caller.
It's truth that was CPI, who's working with Terra to remove term limits. And the excuse to build the system of health control is Trump. How ironic to claim there's a dictator while building your own kingdom of control. Shedding light on the lies, there's no such thing as no cost or free of charge services. Labor has a value. Isn't that what the progressives claim they support? And throwing water on the wicked white coat witches, they support this because it means a bridge to more money from the government death care system. The few profit while the majority get stuck in their net of low-quality delayed care, just like in Canada. And the dictatorial experiment starts with low-income zip codes, of course, because tyrants always care or prey upon the most vulnerable first. Typical disgusting racist county scam. County live unwell, non-sober mobile centers are a plague upon society. Drug addict zombies enter through metal detectors only to receive more drugs to continue the addiction industrial complex. It's not real care. How many people have actually gotten better while these NGO CEOs keep getting richer? It's shameful.
Thank you. And Chair Lawson-Remer, that concludes public comment on this item.
Okay, I turn it over to the Vice Chair.
Thank you so very much. I want to start by thanking county staff, especially Jamie Bean, Dr. Jen Tudor, Eden Berkman, Dr. Hernandez. Thank you all so much, and your teams for getting us to this point. The last board letter was a very broad, try to do with this what you can, so an idea that was really keeping me up at night, having governed through two 100-year events, the pandemic and also the flood, and seeing that we responded as well as we could, but that well, I wasn't at the county with COVID, but with the floods, that, preparation is really the best way to anticipate these disasters, which is what basically we're facing after the election at the end of this year, beginning of next year. So as we've heard today in this presentation and the previous one, we are preparing for significant federal changes that will impact how residents access critical safety net services, and our responsibility is to make sure that no one falls through the cracks during that transition. The Safety Net Bridge program is designed to address a very specific need. It is not about solving every gap in our system. Instead, it is about supporting individuals who are chronically ill but relatively stable, people who are managing their conditions but could lose access to care and food to short-term disruptions in coverage. So while CMS reforms that we talked about it earlier are mandatory responsibility, those reforms are focused on more catastrophic needs among uninsured populations. I think this program is more about continuity, making sure that people don't lose care simply because of an administrative or eligibility change. And so at the same time, we recognize that there is no one-size-fits-all solution. What works in southeastern San Diego may not work in unincorporated North County, and we have to be more thoughtful about those differences. And so I appreciate all the public speakers for being here today. Thank you for coming and expressing your input. I think that I have some favorites in the 1 through 6 options before us. I think 6 is important because it also allows us to streamline some of the services with the proposed and possible CMS reform. So I think that's very important, but I also think 5 is important. It comes to mind, Dr. Flalo, who's not here with us today, but has a very extensive community health fair that sees so many different people, and I certainly wouldn't want to leave someone like her and others like her that are making those efforts on the ground out. So I think we have to move forward, keeping all of these models in mind as we develop the pilots. And by the way, the districts that are, of course, most impacted, those zip codes are D1 and D4, right? And so I think to leave staff with as many options as possible, understanding that, of course, proportionately, most of that will probably land on 6. I am certainly not, I don't feel like we're in a position to leave any of the other options out. And so I think with if a few concepts that I want to lift up that I think are especially important, care navigators certainly will be essential. We heard from our partners that that's going to be one of the most important parts. We already know that. In fact, I was up in Sacramento last week, and that was one of the major asks, that we would have funds, or we could get resources to backfill our employees and even more of them, to make sure that people are not falling through the cracks, Jamie, as you mentioned in the very beginning of the presentation. So we are already working on that. But there's many of these other options I think I don't want to leave off the table until we have fully formulated those pilot programs to see what our districts need. I certainly wouldn't want to cut anything off today that our community members need down the line. And so with that being said, I do want to move this item forward. I think ultimately this is about building a more responsive and equitable safety net that meets people where they are and ensures continuity of care during a time of significant change. But I also would like to add a recommendation if I could, and this is just based on the deadline of the CalFresh requirements, which will be June 1. And so this current recommendation asks you all to come back with those designed pilots in 180 days. We know, obviously, from the curated meetings that we've had and the very much the participation of our partners and the fact that we're Article 13 county and all those things, that the healthcare piece is really a lot more complex. The food piece is complex, but not as complex. We have the FJ cap. We know we can more pinpoint what those needs are. So I would like to add this recommendation just based on the fact that food access support needs to be deployed very quickly. So I would like to add a number 3 to direct the Chief Administrative Officer in coordination with the Office of Sustainability and Environmental Justice to report back within 45 days on implementation plans and cost estimates for the food access component of the Safety Net Bridge program. Thank you, Andrew, for putting it up. And I will go ahead and move that as an entire motion, so that recommendation added to the staff recommendation as my motion. Again, I appreciate everyone. Thank you very much for being such an integral part of this and for putting it into operation what was in my brain, which was not easy. So that concludes my comments. Thank you very much.
Okay, thank you. Chair Pro Tem Aguirre.
Thank you, Madam Chair. I also want to echo my gratitude to Dr. Jennifer Tudor, Jamie Beam, and Dr. Hernandez, and the entire HHS staff for all of their thoughtful and timely work around this very important effort. It's no overstatement that we're facing a real coverage cliff here. As was mentioned, District 1 does carry a disproportionate share of that risk, driven by, as we know, higher rates of poverty, food insecurity, and barriers to consistent care. That is why centering the social vulnerability index in this work is so critical. It ensures resources are directed where the impact will be most severe. And if I noted correctly in the graph, at least 6 zip codes are in my district that are the most likely to be impacted by these work requirements. I think all 6 options presented are thoughtful and responsive to community needs. However, I would like to highlight the options that I feel will most effectively address gaps in care left from the fallout of Trump's disastrous H.R. 1. I particularly see value in options 1 and 6. Telehealth allows us to scale quickly and reach residents who may not be able to access physical sites, while partnerships with community health centers build on trusted relationships and existing infrastructure, which is essential for continuity of care. I also support option 5 as part of a broader system that connects individuals to ongoing care rather than operating in isolation. Community-based models, including health fairs and Live Well on Wheels, help close geographic gaps and bring care, medications, and food directly into communities. At the same time, I do want to acknowledge the trade-offs with the other options. Expanding brick and mortar or county-operated clinics requires significant upfront capital, licensing, and staffing, and may take longer to deliver services at scale. Given the urgency of potential disenrollment, we need approaches that are both cost-conscious and rapidly deployable. I also want to emphasize the need for a comprehensive education and outreach plan. In San Diego County, no one should believe that losing coverage means losing access to care. We need clear communication and rapid re-enrollment pathways to prevent unnecessary gaps in treatment. As this moves forward, it is important that the final plan reflect the realities of all of our districts, but especially District 1, which is going to be the most impacted, where the risk and impact are highest. I would also like to see a clear strategy for coordination with community clinics, hospitals, and trusted partners already serving these populations. I also want to express my support for the added recommendation. I think it's wonderful. Thank you for always having that on your radar. The food insecurity is a big one for me too. So I really appreciate your thoughtful addition to this motion. And I look forward to seeing the pilot implemented in a way that meets the urgency of this moment and that can be scalable across the county. And with that, I'm happy to second unless the chair wants to do that. Okay, thank you.
Okay, Supervisor Desmond.
Thank you, Madam Chair. Appreciate it. You know, this is
Very interesting article, and I do think we should be utilizing our Live Well centers as best we can and providing the services that residents need. However, I'm not in favor, and I'm glad this is just basically coming back with a plan. And I think we heard from many of the residents, especially the healthcare providers today, that we shouldn't be competing with each other. We should be, working together. So I don't think the county should be in the business of establishing healthcare clinics and duplicating the work that our great health clinics and partners already do. This option is extremely costly, and where the county, I think, and not where the county should be investing. And I do agree with one of the speakers. Every dollar that could potentially go out to any of these options in this report should instead go to self-sufficiency services to ensure that we're fulfilling our responsibilities. And I think the county's role is to ensure that those who are eligible for benefits continue to receive those benefits. That we make sure the ones that people that need it continue to get the benefits. Our primary concern should be that no one who is eligible for CalFresh, Medi-Cal loses coverage because we haven't invested in our department properly. But my office has heard from several providers, including healthcare partners that represent 17 healthcare providers, including TrueCare, San Ysidro Health, and Imperial Beach Community Clinic, that we should not be duplicating these efforts. So I'm going to go ahead and support the item today, and then take a look at the plan that comes back. And hopefully the pilot program doesn't include some of these more expensive options right away, and that I'll take a look at the options when they come forward. Thank you.
Okay, thank you very much. Go back to the Vice Chair.
Just really quick, I appreciate that, Supervisor. And I really just want to be clear that we have been collaborative in this effort, and we've been communicating a lot with all of our healthcare partners. And so I appreciate that support and agree with you, but just want to make sure that as staff develops the pilot that we're leaving all the options on the table. But I do appreciate you. I just want to make sure that everyone knows that we have not left anyone out of these conversations. We've been very actively engaging our partners. Thank you.
Okay, thank you very much. There's a motion on the floor in a second. Please vote.
Chair Lawson-Remer, that motion passes unanimously with all supervisors who are present voting aye.
Okay, thank you all very much. Great. So we'll now move on to item number 28, which is return on a children, youth, and transition age youth behavioral health continuum framework. Nadia, if you feel free to start whenever you're.
Sorry. Good afternoon, or good morning, Chair Lawson-Remer and members of the board. To address the growing public health.
One moment. Folks who are leaving, please, if you can be respectful of the presenter. And if we could shut the door to our deputy standing there, if we can get that door shut so that, sir, could we get the door shut in the back? Thank you. Thank you. Okay.
All right. Good morning, Chair Lawson-Remer and members of the board. To address the growing public health concern of youth mental health, the board approved actions in September of 2024 to create a behavioral health continuum.
Hold on, Nadia, pause. We have two people who've gotten up. Okay, we're back in session. Please go ahead, Nadia.
Thank you. To address the growing public health concern of youth behavioral health, the board approved actions in September of 2024 to create a behavioral health continuum framework for youth and transition-age youth, or TAY. Today, we are returning to present the Youth Optimal Care Pathways Model, or Youth OCP model, which was developed based on analytic modeling, and we will outline strategies to improve engagement and expand access to care. The Youth OCP model promotes well-being amidst the increasing anxiety, depression, bullying, suicide risk, and social media influence, and it emphasizes strengthening family supports. The model was developed in collaboration with key county partners, including Child and Family Wellbeing, the First Five Commission, along with external stakeholders. With me today to present this item is Deputy Director Yael Koenig. Expanding access to care is a critical step in addressing the mental health challenges facing young adults, and recent data highlights the urgency of this need. Between 2019 and 2023, emergency department visits for non-fatal suicide attempts and self-harm increased by 24% amongst 10 to 17-year-olds, who have the highest rates compared to all other age groups. The California Healthy Kids Survey provides additional insight. More than 10,000 students in grades 7, 9, and 11, as well as continuing education students, were asked about key mental health indicators. At the time of the survey, 28% reported feeling chronic sadness in the past year, and 10% seriously considered attempting suicide. 36% said they felt lonely, and 24% reported feeling emotional distress. Although 68% of the students reported emotional support from an adult at home, the survey suggests nearly 1/3 may lack a strong support system at home. BHS recognizes that supporting youth requires a coordinated collective effort. To ensure youth are successful in accessing and staying connected to care, collaboration is needed across many partners in various sectors, several of which are illustrated on this slide. Each plays a distinct role and carries specific responsibilities and funding driven by statutory requirements, all of which shape how the system supports youth. As a region, stakeholders come together to inform and strengthen services for young people. Stakeholder engagement was critical to informing the recommendations that will be presented today. Beginning in April of 2025, BHS conducted numerous engagement activities to hear from those who are most central to the youth system of care. The Behavioral Health Services Act, or BHSA, community program planning process was also leveraged to ensure alignment with broader system strategies. In total, 200 stakeholders, including youth and their families, community-based organizations, education and healthcare partners, advocacy groups, and Health and Human Services Agency staff participated, providing both written comments and verbal feedback. And several insights emerged. First, early behavioral health concerns are often identified at home or in school, highlighting the importance of caregivers and educators in observing health changes and helping kids connect to care. Second, stakeholders emphasize the importance of culturally responsive services in everyday settings. Third, schools were identified as accessible and trusted entry points for early mental health support, especially when services are available on campus and when care pathways are clear and coordinated with families. Finally, stakeholders highlighted the importance of strong coordination that allows schools, providers, and CBOs to share information to align interventions. In alignment with what we've learned, today's action requests authorization for the procurement of school-based early intervention programs, as well as direction to establish data sharing agreements amongst county departments and healthcare entities. As mentioned earlier, a collective commitment across partners is needed to holistically support young people. And for the system to be effective, broad clarity and understanding is necessary across key areas, including the needs of youth and families and the level of services required, the county's scope and responsibility for services, including crisis and acute care, and the regional landscape to ensure partnerships support integrated, coordinated care. As a county behavioral health plan, our statutory responsibility is to provide specialty care services for Medi-Cal eligible youth with significant mental health and substance use conditions, or with conditions that could lead to significant impairment. Currently, BHS funds a broad network of treatment services as part of the broader ecosystem. As of September 2025, more than 373,000 youth and young adults ages 0 to 25 in San Diego County were enrolled in Medi-Cal. Based on state-level survey data, about 27%, or 100,000, are estimated to have a need for some level of mental health treatment. And of those 100,000 youth, about 67,000 meet criteria for specialty mental health services through BHS. Yet only about 19,000 received BHS services last year. Additionally, among San Diego youth ages 12 to 25 enrolled in Medi-Cal, approximately 40,000 need substance use treatment. These figures highlight the importance of expanding engagement, access, and service capacity so all young people who need care are able to receive it. With that, I will now hand the presentation over to Yale to outline the framework of the Youth OCP model.
Thank you, Nadia. The Youth OCP was developed with several key principles in mind, with a deliberate focus on ensuring access to care. First, it recognizes that age and developmental stage matter. For that reason, 4 main age groups were considered: early childhood, latency age, adolescents, and young adults through the age of 25. The model is also informed by local penetration rates and how San Diego County compares to state benchmarks, which indicates that our network needs to serve more youth. Next, it remains critical that youth are connected to outpatient care, where families can get support to build new skills, address trauma, and build long-term wellness. Diversion from emergency departments, when possible, is important because there are more effective support in dedicated crisis response setting. Access to intensive community-based services and smooth transitions across levels of care is also a key focus. Lastly, ensuring adequate access to residential treatment is critical when community-based care is not sufficient. Residential capacity is also imperative to ensure youth do not remain in acute care settings long-term. These guiding principles inform the development of the Youth Optimal Care Pathway model, which focuses on building capacity across 4 distinct areas, which also align with the Strategic Behavioral Health Initiative. Next, we will review each of those areas. For early intervention and outpatient care, it's important to note that the transition from the Mental Health Service Act to the Behavioral Health Service Act, or BHSA, shifts prevention funding to the state, with counties focused on early intervention. Early intervention includes outreach, access and linkage to care, and mental health and substance use treatment. The Youth OCP model assumes that every youth will have access to early intervention and outpatient services to support healing and prevent symptoms escalation. The model projects capacity growth over the next 5 years. These numbers are dynamic and expect to evolve. As the landscape changes, so does the model. The outpatient mental health services, we are projecting a growth of 29%, or just under 5,000 additional youth through the age of 25. For substance use outpatient treatment, the focus is on youth ages 12 through 17, and the model projects a 43% increase, or nearly 300 additional youth to be served. When a crisis occurs, youth should have access to care that is designed with their developmental need in mind. Expanding capacity in this area will help divert youth from emergency departments and into more appropriate crisis response settings. Crisis services that serve youth include crisis stabilization unit, mobile crisis response teams, and a new crisis residential program, which would allow for a more prolonged crisis treatment episode needed to achieve stabilization. Over the next 5 years, the model projects a 164% growth in crisis services, representing about 5,000 additional youth. Intensive community-based services are also instrumental in preventing hospitalization and serving as a step down from acute care. Wraparound services offer care coordination focused on strengthening natural support systems and preventing out-of-home placements. The county is also looking at opportunities to expand mental health intensive outpatient programs and partial hospitalization programs, or IOP and PHP, which have been long available in the private sector and are now available within the county system. These programs allow youth to receive intensive services during the day while continuing to reside with their caregivers. For substance use treatment, the county has redesigned its approach for outpatient treatment, allowing programming to focus on delivering intensive services. Over the next 5 years, the model projects 72% growth in mental health services, representing more than 450 additional youth, and 127% growth in substance use services, or nearly 90 additional youth each fiscal year. Under the umbrella of residential treatment, there is a new designation known as the Psychiatric Residential Treatment Facilities. BHS will be working with local CBOs who receive state grant funding to establish this service, which will provide an important alternative to acute care setting. Short-term residential treatment programs primarily serve foster youth and provide specialized care with the goal of transitioning the youth to a less restrictive setting. The intent is always to serve youth in the least restrictive setting that meets their needs, with strong emphasis on community-based care. The projected growth in residential services is relatively modest, with an estimated increase of 25% of mental health services and 42% for substance use services. Overall, there is a projected growth across each level of care over the next 5 years. The model prioritizes early intervention and outpatient services while also strengthening crisis response, intensive community-based care, and residential treatment when needed. The largest growth is projected in crisis response. And now we will highlight several ongoing efforts to enhance youth services locally. First, Mobile Crisis Response Teams, or MCRTs, have expanded to school campuses through partnership with the County Office of Education and school districts, and utilization continues to grow. The new Children's Crisis Residential Care Facility, funded through Proposition 1 bond funds, is being developed within a vacant space adjacent to the Polinsky Children's Center campus. When completed in 2027, it will be the first of its kind in the state. In addition, the Youth Crisis Stabilization Unit remains a vital part of the crisis network by offering support to youth experiencing crisis and engaging their caregivers. BHS is assessing the need for additional CSU capacity that would support youth regionally, including a hybrid model that serves youth and adults. To ensure effective engagement in the services outlined in the Youth OCP, BHS has introduced 3 pillars that ground this work. The first pillar focused on school-based strategies. We recognize schools as a natural access point and critical partner in supporting youth behavioral health. Therefore, we've identified strategies to strengthen collaboration with schools, including enhancements to mobile crisis response teams, supporting data-driven evaluations of student needs, engagement, and outcomes, working with school district to redesign services offered on school campuses to ensure they're sustainable long-term, and leveraging the Children and Youth Behavioral Health Initiative fee schedule, which allows schools to bill for outpatient services at no cost to families. Today's action requests authorization for the competitive procurement of 2 early intervention programs, the School-Based Incredible Years and the School-Based Skill Building Program, which have been redesigned to allow for Medi-Cal reimbursement. The second pillar focuses on strengthening family systems. It recognizes the critical role caregivers plays in supporting children, for which we've outlined several key strategies. BHS will leverage state initiatives to expand evidence-based practices that support a family system approach. It also emphasizes creating culturally and developmentally appropriate environments and connecting youth and families to enriching care spaces. In addition, BHS will strengthen partnership with community organizations to improve access to supportive environments for youth and families to thrive. And lastly, improved data sharing across care system will remain a key strategy, so providers can better understand each youth's needs and effectively coordinate care. Today's action requests authorization to update or establish data sharing agreements across county departments, including BHS, Child and Family Wellbeing, and Probation. And finally, financially sustainable partnerships with hospital system and other providers to enhance integrated care, increasing collaboration with managed care plans, particularly by maximizing the use of Medi-Cal-covered services, and continuing to advocate for state policy changes that make integrated behavioral health more sustainable, including simplified billing requirements and reliable reimbursement structures. To help improve care coordination and support timely access, today's action requests the board to direct formal discussion with local hospitals and managed care plans to establish data sharing agreements. I'll now hand it back over to Nadia to wrap up.
Thank you. In closing, today's actions request the board to receive the update on the youth OCP model, authorize competitive procurements for school-based incredible years and school-based skill building programs, establish or update data sharing agreements between the County of San Diego departments, and authorize formal discussions with local hospitals and managed care plans to establish data sharing agreements. Thank you. This concludes our presentation. We are now available for questions.
Thank you so much for the presentation. Andrew, let's go on over to public comment.
Thank you, Vice Chair Montgomery Stepp. We have 12 requests to speak on this item, 4 in person and 8 requesting to speak by phone. Also note for the record that we received 4 e-comments, 3 in support and 1 in opposition. For any individuals that requested to speak on item 28 by phone, please dial into the conference line using the instructions that were provided to you. We'll begin with the in-person speakers. As your name is called, please come forward. Again, because there are 10 or more speakers on this item, you'll have 1 minute to address the board. I'd like to invite forward the individuals in person: Alfredo Aguirre, allegedly Audra, Cesar Javier, and Catherine Rhodes. If I've called your name, please come forward. And I'll ask you to begin by stating your name for the audio record.
Members of the board, good morning. My name is Alfredo Aguirre. I'm a retired behavioral health director for our county. It's good to be back after 7 years. I am the chair of the Strategic Behavioral Health Initiative, also known as SBHI, a coalition of pediatric and youth behavioral health providers, pediatricians, child psychiatrists, school-based mental health providers, substance use experts, and community-based organizations and county representatives serving San Diego County's 672,000 children and youth. San Diego County has a rich history in children's mental health system development. In fact, under the board's leadership, San Diego County established the first separate children's mental health department in the state in 1999, later to be reintegrated with the adult mental health system. I'm speaking to you today because we support the Youth Optimal Care Pathway Framework and the corresponding actions before you today. In addition to my comments, our coalition has submitted letters to the board.
Thank you. Thank you. Thank you. Next speaker, please. If I've called your name, you can come forward in any order.
Woe to you guys. This is so egregious what's happening to children in this county at the direction of this board and your staff and the behavioral health Matthew 18:6 and Luke 17:2. I suggest you read it because it would be better for you to have a millstone hung around your neck than to make one of these little ones stumble. You guys are putting children through behavioral health therapy because they are having a hard time being ripped apart from their families. You're putting them on psychotropic drugs. You are encouraging their behavior to change so that they don't get upset when they don't see their mother, like Malika and Zaya Robinson have been put through behavioral health therapy to make the transition to a new family better, to change their behavior so they don't cry and beg and plead to go home. Tara, what if that was your daughter and they said, your daughter doesn't need to believe all the things that you do. They're going to change her behavior by putting her on medication so that she is okay with being ripped apart from you. Imagine if it was her.
Next speaker, please.
Hold it. Thank you, Uncle Sam. We're here again to voice our concern and our will to help our government. You see this, Ma'am Rimmer? This is air pollution reader. And the toxicity that is killing us impacts the creation of God in His image. We saw you, Mom Rimmer, how you cared of your child in your lap during the APCD meeting last December of 2024. Thank you for showing us your concern to children. And what is APCD doing? Air Pollution Control District is for business.
Thank you.
Thank you.
Next speaker, please.
Hello, Catherine Rhodes. And first, the presentation was not part of the backup documentation, so I'm not prepared to speak fully. In the future, please actually have it there so I could see. And how many beds are going to be in the new building next to Polinsky Center? I didn't actually get that. And then I wanted to tell you about, again, my issues, and I agree everything with Audra said. It's a crime. Child Protective Services from our family had over 30 calls for intervention from schools, from doctors, from everybody. And the child was only given, and then it went to the Polinsky Center, and the child was only given the opportunity of going back to her abuser or going to foster care. She wasn't allowed to be in kin placement with me. Now she is in kin placement. Well, she actually got a domestic violence restraining order for physical abuse, sexual abuse, coercive control, everything. And your policies all have that, but they refuse to give us a safety plan. Can you force your staff to actually give safety plans for children who are speaking out? Thank you.
Thank you. We'll now hear from the individuals that requested to speak by phone. We will start with our first caller.
All about. I was looking forward to a report from behavioral health of some real progress, but what have we got for our money? Pretty much nothing, apparently. Instead, we get token or meaningless phrases. BHS quotes a survey with a lot of, quote, mays. And you want to spend our money on this? On page 13, the board letter says the county was awarded an $8 million Prop 1 behavioral health continuum infrastructure grant funding to build a new children's crisis care facility, which led a whole 60 new beds within the Polinsky Center building. With all the crimes and crap at the Polinsky Center, 16 more beds there with all that stuff going on is a total waste of money. 18 months without positive results.
Thank you. We'll hear from the next caller.
Good morning. My name is Becky Rath, and I want to start by recognizing
the work behind this behavioral health framework because expanding access and focusing on youth is absolutely the right direction. But I would like to raise one concern. Are we truly building a continuum of care? It must include prevention, and that means directly addressing youth marijuana use as a contributing factor to this behavioral health crisis. We're seeing rising rates of anxiety, depression, and suicide risk among young people, and research shows clear links between adolescent marijuana use and worsening mental health outcomes, including increased suicidal thoughts and risk of psychosis. Yet this plan focuses heavily on treatment and crisis response, with little attention to preventing substance use in the first place. I support this effort, but I urge you to strengthen it by including meaningful marijuana prevention education, because a true continuum doesn't just respond to crisis, it works to prevent it. Thank you very much.
We'll now hear from the next caller.
It's truth. Here's Manuela's comments on every item. Trump, 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 Trump. Isn't it ironic to complain about federal policy changes, but then bend over and take a knee for some state policy changes that harm children? The Behavioral Services Act targets children with tests and drugs while at school without parental knowledge or consent. And this $10 million anti-child item proposes sharing children's private health data with county departments and private hospitals. This is child exploitation. According to HHS Clearinghouse, there's only been one study of the school-based Incredible Years program, which consists of social-emotional brainwashing videos for 6-year-olds with a fake diagnosis of oppositional defiant disorder. And it consisted of almost all white boys in Washington. So much for equity, data-driven decisions. IT consultant Malaysia Guzman gets 2 paychecks by working for both Incredible Years and its parent corporation, Empower Community Care. I don't want this board anywhere near children. No programs, nothing. Leave the children alone. Go audit Polinsky or East Mesa and then come back and tell me you care.
Thank you. Hear from the next caller.
Okay, Consuelo. So yeah, pointing out the obvious marijuana use is cute, but it's the true prevention is acknowledging the source of the problem, and that is the system. So, I mean, talk about marijuana all you want, but it's an escape. So until you get to the root of the problem, which is the system of why they need to escape, then you're never going anywhere. Anyways, okay, so of course there's no support at home. The system has taken the place of strong family units. It's done everything in its power to destroy the family unit. The system has taken the place of moms and dads. Schools have encouraged for their students to hide things from their parents, life-altering things. I mean, it's not rocket science to see the pattern and the result of why things are the way they are. The system creates weak, vulnerable, docile, dependent beings, and then wonder why these children are at risk. Nothing is solid anymore. Nothing is guaranteed anymore. The only thing that we rely on is, at this point, is the system is a consistent failure. And crisis after crisis, that's the business. You can't have a product without a target demographic. Early intervention, you can't have healing. How will you fill the jails?
Thank you. We'll now hear from the next caller.
Good morning, Chair and Supervisors. My name is Erin Hogeboom. I'm the Director of San Diego for Every Child, co-lead of Children First Collective, a supporter of the SBHI Collective Comments, and a mother of a 4-year-old. Thank you for the opportunity to comment. First, I want to recognize BHS for advancing this important work amid significant systems changes and multiple overlapping mandates. These efforts are really appreciated. In particular, I'm encouraged to see an action item for data sharing. My main concern is with this iteration of the plan, it's just that young children and their caregivers are largely absent, even though we know mental and behavioral health needs often emerge early. The plan also leans heavily towards crisis response, which looks very different across age ranges and risks reinforcing a reactive system instead of one rooted in prevention. I urge the county to explicitly include children, especially young children, and support the cross-departmental sharing on their access and wait times through stronger collaboration with First 5, the Children and Family Wellbeing Department and schools, to strengthen prevention and early intervention in the form of early
Thank you. We'll now hear from the final caller.
Good morning, Board of Supervisors. Ann Riddle, a retired social worker and now volunteering with youth programs from which I am calling today. I like the fact that we're spotlighting this situation. I think we miss a great deal on this continuum. First of all, I didn't hear enough about transitional youth, and as all of us who work in foster care know, that tragic age of 18 to 25 who've come out of foster care without the help and support they need really needs to be addressed, and of course contributes to their mental health and substance abuse. But we forget prevention, particularly community-based and family-based prevention strategies. Parents are the first line of defense for our young people because that's who, after all, spends the most time with them. Then come our schools, but then come our community. And it becomes very incumbent upon us in the community to send messages to our young people that this is a safe place and that we know and will provide for them safe environments, that our streets will be clean, our neighborhoods will be well lit, and they'll be protected.
Thank you. We'll now hear from our final caller.
You know, it's surprising to me because you are actively trying to separate families because you make money off of it. It generates money for California, every family you separate. It generates money for all the programs and all that stuff. I mean, hell, didn't you guys add like $10,000 for every person that they could put into foster care? You're basically creating a lot of victims and you're profiting off of that. And then you go ahead and claim that you're actually wanting to help these people? That's just a bunch of bullshit. I mean, it's the same reason why you keep the whole COVID mandates is because you could make money off of it. That's why you allow problems to fester, because you could make money off of it. That is why you're not going to do a damn thing about the landfill until it becomes a critical issue where you're going to make money off of it. Instead of doing something preemptive.
Thank you. And Chair Lawson, public comment on this item.
Okay, thank you so much. Just want to, before we move to board discussion, thank the team. This item was in response to a board letter I brought quite some time ago, and want to give context to that for both my colleagues and the members of the public who might not recall the origin. But, you know, we've made a pretty much a 180 shift on how we tackle behavioral health in San Diego County over the last 5 years. From a model that really just looked at being the behavioral health provider of last resort when people had spiraled down and down and down and had nowhere else to go and we had to meet a legal obligation, to instead thinking about how do we help people before things become so terrible, and how do we be more proactive in getting people the care they need, both because it's the right and humane thing to do, but also because it's the significantly more effective and cost-effective way of intervening. You know, we know that it is significantly more expensive to treat folks once they're sort of in a schizophrenic state or in a psychiatric hospital or really struggling with addiction and things being really, really bad. And so that was the origin of kind of the shift in how we are tackling behavioral health across our region in general, which is amazing, and really appreciate the partnership of everyone on this board as it really being a bipartisan effort to transform and make more effective and more cost effective, both things, how we tackle helping people in San Diego County. But there was a significant gap in that optimal care pathways, or as I prefer to call it, the care before crisis model. And that gap was for young people, for youth, because youth do have different, not just different needs, but also there's different gaps, different kinds of providers, different kinds of services. And so I had asked the team to really take a look at how to take the model of an optimal cares pathway that we had developed for adults and apply it to young people. And I think you all have done an amazing job. Really appreciate the work that's gone into getting input and feedback from stakeholders, because our stakeholders are the ones who are boots on the ground, sort of closest every single day to what the needs are and what the crises are that are being faced by young people in our community, and that's what this is. So thank you for the work. Thank you for the update. I think we got to just keep moving forward. Do think it's important to make sure the whole board is fully informed. So I do hope that my colleagues who maybe have been a little bit less close to the details of this can take an opportunity to ask you any questions. Again, as I know that although there's a lot of areas of disagreement on our board, this is definitely one area of congruence that we've all been rowing in the same direction. So with that, just thanks again, and I'll open for the board discussion. Chair Pro Tem Aguirre.
Well, thank you for your leadership on this issue. It's incredibly important, and it's important for us to make the way that we reach our youth more efficient and more effective. So thank you for that work, and I thank the team for it as well. We know that we have at least 100,000 youth enrolled, well, 373,000 youth enrolled in Medi-Cal, and at least 30% of them need mental health treatment. But we know that at least 1 in 3 don't have access to care. So, and that is a reality. So I think this proposal moves us in the right direction. I know that we need to turn this into consistent delivery. So that means having a workforce, building our workforce and building our capacity in a way that translates real engagement and in a way that gets to our young people earlier and more consistently. So I'm very supportive of the item and hope to see it become something that our youth can really use. Thank you.
Seeing no other comments, I'm happy to move the item.
Second.
Okay, we have a motion and second on the floor. Please go ahead and vote.
Chair Lawson-Remer, that motion passes unanimously with all supervisors who are present voting aye.
We're going to do it right now. You do need to do that. You need to. Okay, thank you all. So I'm just kind of like trying to get ourselves in order for the remainder of our meeting, because a reminder to please be respectful in the chamber and allow us to conduct our business. If people are disruptive, you will be asked to leave. So obviously we had a lot going on yesterday. We're still on yesterday on our items. And then we also still have closed session today, plus our land use items. So I had my team kind of map out when we're going to finish, based if we just sort of continue on with all the items in order. And it has us going till almost 8 o'clock tonight. So trying to figure out some efficiencies here. There has been, it's been communicated to Andrew that the following items would like to either be continued or withdrawn. So I wanted to address those now. If we could address those now, then at least we can maybe finish by 6:30 instead of 8. That would be preferable, or preferable, I should say. So what I do know, let me just put this out there. I know that item 20, which is Anderson's item, it seems appropriate to continue that item. So I would make a motion to continue that item. I know that item 9, I think this was your item, Supervisor Desmond. What? And you want for Wednesday, and you wanted to continue that item? Okay. So we have 2 items, well, because I think you have to leave, so we wouldn't get to it and you will be gone. So, okay. So we have item 9. We will have item 9 that will continue. Item 20 that I would, this would be my motion to continue items 9, item 20. And if there's any other items that folks don't want to take today, now would be time to mention that, and we can take this as a bundle.
Yes, Madam Chair, I'd like to withdraw item number 22.
Okay, so there's, looking at withdrawing item 22, that's a motion from Supervisor Aguirre. Looking at continuing item 20 and item 9. Any other items that people want to make sure they talk, that they're here for? I think Supervisor Desmond, I am somewhat concerned. I think you have another item. Okay. Oh, okay. I don't know, maybe, but we'll see. Okay, so we'll continue on with that. Any other items from the CAO that you'd like to continue?
Thank you, Chair. No.
Okay, so we've got those 3 items. I think and so if there's a second to that, then we can take public comment. And then we would be able to continue these items, continue those 2 items and withdraw that 1 item. Okay. Great. Do you want to repeat that, Andrew, so everyone's clear?
Thank you, Chair Lawson-Remer. For the record, the motion by Chair Lawson-Remer, seconded by Supervisor Desmond, is to continue item 20 to the next meeting, April 21st, withdraw item 22, and continue item 9 to the next land use session, which is April 22nd.
Okay.
Chair, I just have a quick question. So for the land use items on consent, are any of them items that we would not be able to vote on based on availability?
There are. So we're
Okay.
trying to get there before we lose Supervisor Desmond.
Okay, so thank you.
Yeah. Great. Okay. So let's go ahead and to take public comment.
Okay, great. Thank you so much. So individuals that are speaking on items 20, 22, and 9 on the land use session agenda can speak to the continuance or the withdrawal, depending on which items you are speaking on. I will note for the record that we have 16 speakers on these items, 6 in person and 10 requesting to speak by phone.
Great.
And I'll note that we received 2 e-comments in support for item 20, 1 e-comment in opposition for item 22, and I'll pull up the record for item 9 in a moment. For those that requested to speak by phone on items 20, 22, and 9, please dial into the conference line using the instructions that were provided to you. We'll begin with the in-person speakers. As your name is called, please come forward. I'd like to invite forward the first 3 individuals, allegedly Audra, Cesar Javier, and Enrique Christofferson. And I'll note for the record that item 9 had 1 e-comment in support. Thank you.
I just feel like you guys can't even plan a meeting out. So that, I mean, if you knew yesterday you have all these time certain items, why are we stacking? What's happening? Why are you, Jim? I feel like you're trying to cut my throat or something. That is. Thank you, Andrea. Are you starting it over? Or you didn't even start it. I shouldn't have said nothing. Let's just keep going, right? Yes, so, I mean, if you guys can't plan a meeting productively when you know that yesterday there's all these time certain items and you stack the deck so thick that we can't even get business done because you guys got to get out of here, right? You guys have things you got to do. No need to spend time really helping things. But, you know, it's good because pretty much anything that you guys do and pass is very egregious, just like that last item. You know, putting children into a psychiatric ward at the Polinsky Center. That place should be burnt to the ground. I literally hope one of the children does it and they get everybody out in the process because those places, and when you do business like that, I mean, it's great if you continue it because then it gives us a little bit more time without you guys destroying the world around us all while you ask us to pay you more money to do it. So I'd like to give a moment of silence to all the children that are being abused by you guys right now.
Next speaker, please.
We have been studying our Constitution, if only to find out in these processes the word accountability. And we are approaching to the limit of our intelligence. All these items are very important. These are all meant to ensure that San Diegans will survive for few more years, particularly the victims of toxicity like us. A neighborhood who established, located, and operated a toxic generating home business. And the worst is the neglect and ignorance, or whatever adjective we could say, or verb, the victims of Tijuana River Valley pollution crisis. These are all the rays or the angular approaches, hopefully. Thank you for your literacy. Thank you for intelligences, and God help. If you cannot step down, we are ready to take over.
Thank you. As the next speaker is coming forward, I'll invite the remaining speakers in person. Catherine Rhodes, Laura Irwin, and Maureen O'Connor.
Thank you, Madam Place here. All right, Enrique Christopherson for item 9. Good afternoon, everybody. My name is Enrique Christopherson. My company is called Response Ready CPR1, and we're a woman small business located in Oceanside, your district, sir. With the recent passage of AB 310, many organizations are now navigating how to meet the new AD requirements in a compliant and sustainable way. I'm reaching out to you as a potential partner based in San Diego County who shares your commitment in protecting the well-being of our residents. I would welcome the opportunity to collaborate and explore how we might work together to facilitate AEDs, help the county, sports, and community organizations understand their responsibilities under AB 310, provide guidance, cost-effective, compliant AED implementation maintenance, expand accessible cardiac emergency resources throughout the San Diego County, strengthen public awareness and community preparedness. I thank you for your continued leadership and your dedication to the safety of the communities that you serve, sir. I look forward to the possibilities of partnering with you. Thank you.
Hello, Catherine Rhodes, and I'm here for number 20, establishing a framework for Board of Supervisors ad hoc subcommittee that demonstrates transparency and accountability. Thank you, Supervisor, I believe Desmond and Gary, I think you're bringing this forward. You know, what I would like to add is I would like the ad hoc subcommittees that we're not allowed to know when they are, or, you know, even what was on the agenda. I would like them to have at least the agenda, and I would like them to be videoed, just like this meeting is videoed, so we could see it on YouTube and see what you're talking about. I have no clue what you're talking about. And if it's money, I know where the money is. I would love to be able to present your financial committee or whatever it is with funding opportunities so that we could spend all this money to help as many people as possible. So thank you so much for bringing it. I'll wait for next time it comes forward. Thank you.
Thank you. Final call for Laura Irwin or Maureen O'Connor. We'll now hear from the individuals that requested to speak by phone. We'll start with our first caller.
You know, I don't know why I try to still maintain faith that some of you guys will recognize what you're doing is wrong and seeing an out that you can take and get off the dependence of the NGOs. But I'm beginning to think that that is just a dream that you actually want to go ahead and help us instead of And if you're pregnant, Tara, you're setting up your kid's future by the actions that you're taking place today. You're going to make it nearly impossible for your kids to progress. I hope you recognize that. Because right now, we could go ahead and generate a lot of money recycling the plastic and fix our infrastructure and fund a lot of projects that would.
Thank you. And now hear from the next caller.
Paul LeBold. On number 20, having all the agendas and other info about ad hoc committees in one place would be a great improvement. It would make research easier, increase transparency, and promote public discourse, and hopefully more good ideas. In fact, 2 supervisors just claimed they can run an ad hoc committee without complying with the Brown Act requirements like notice, agenda, and minutes, and they apparently even issued contracts. It might be a bit expensive, but I think it would be well worth it to subject these ad hoc committees to the Brown Act standards of open government, since these committees do not seem to be covered, and they may be created to maintain secrecy in government. The county motto is the noblest motive is the public good, so show it. 9 is an interesting item, perhaps it.
Hear from the next caller.
Hello, this is Peggy Walker. I just want to say that the steamrolling yesterday of item 19 seems to have evolved without adequate public awareness or notification to the district attorney. It's a prime example of why we need item 20, the transparency and accountability framework. No validated data demonstrating need for the separate unit was presented, or validation for the cost. But this essentially duplicates a successful existing unit in the DSA's office, but there was no validation for capacity of the county to effectively operate it and responsibly control the funding, in spite of Superintendent Anderson's request to stay the vote, to consult constituents and suggestions by the DA for coordination. The chair.
Hear from the final caller.
Okay, Consuelo here, and looking at item 20. And yeah, just ditto to everything Paul mentioned, Paul the Bold. And yeah, that's all I got to say. I'm paying attention. I'm tired. I'm hungry. And yeah, on to the next item. Thank you.
We had one more caller join the queue.
Good afternoon, Board of Supervisors. Thank you for this opportunity to mention my support for item 20. I'm really appreciative that this item was brought forward by our Supervisor Anderson and Aguirre. This means a great deal to me because I've always thought the Board of Supervisors does its work in the dark, and you don't seem to have a committee process or a commission process like all the other cities that surround us here in the unincorporated area that allow us to come in and talk about wide-ranging issues. The excuse given that it's just for a short period of time just doesn't fly. We all have the same issues. We've had them for decades. We need committees that operate, that give us the chance as people here across the county to come in and share what's important to us. That old saying that things prosper in the sunshine holds more true than ever. To do things in the dark that we don't have access to, don't know about, can't understand. So unlikely.
Thank you. And Chair Lawson-Remer, that concludes public comment on these items.
Okay, thank you very much. We have a motion on the floor in a second. Please vote.
Chair Lawson-Remer, that motion passes. all supervisors who are present voting aye.
Okay. Thank you so much. We're going to take a little bit of lunch. I can take remarks for item 21 to kick us off. Go to public comment. This is just part of an ongoing drumbeat, right? Which is to really focus on everything we can do to save taxpayer money, particularly in this time of fiscal constraint and fiscal uncertainty. It's always a priority. It always needs to be centered and top of mind for how we can be as efficient and fiscally responsible with people's hard-earned taxpayer dollars. And that is constantly top of my mind. But I think that at this moment, there's just a requirement to be even more diligent and even more focused. So, as we face this federal withdrawal and, a lot of economic uncertainty, rising oil prices, et cetera, we clearly can't control what happens in Washington, but we can focus responsibly on what we steward. So we've been looking very hard at our own operations, looking for every opportunity to find operational efficiencies and save taxpayer funding. So we previously brought other items that looked at taxpayer savings on county office space, on phasing out old tech like fax machines, on fire station upkeep and maintenance. So responders, first responders could change their own light bulbs. This item looks at our county fleet. It's not the kind of thing that ends up in the headlines, but it is a really important efficiency. For context, we have about 4,500 vehicles. Not all of them are fully utilized, and we rely on departments to self-report usage data. So this item will add GPS to get objective numbers, identify what vehicles can be retired, and move toward a shared county system so departments redeploy between operations before they buy new vehicles. Which will mean lower maintenance costs and avoided capital costs over time. So proud to be part of a fiscal subcommittee that's focused on fiscal responsibility, and we'll turn it over to Vice Chair Montgomery Stott.
Thank you so much, Chair Lawson-Remer, for your collaboration on this item, and I would also like to thank county staff. While we cannot control funds lost from both federal and state government, we can control how responsibly we steward public resources and protect the services our residents depend on. So through the work of the Sustainable Fiscal Planning Subcommittee, we are committed to continuously finding smart and effective ways to cut costs for our taxpayers. This item is part of a broader effort by the county and the Sustainable Fiscal Planning Subcommittee to identify efficiencies and cost-saving opportunities before any service reductions are considered, an effort that has already begun to see savings through modernizing county communications technology and centralizing space management. For this item, county staff estimates 104 vehicles could potentially be reduced from the fleet, potentially saving the county approximately $5 million to $5.3 million in cost avoidance over the useful life of a vehicle. This figure reflects both avoided vehicle replacement costs and reduced life cycle maintenance expenses. For example, to replace an existing vehicle, the average cost for a new electric vehicle is $77,000. Additionally, it costs an annual average of about $1,100 per vehicle, $1,100 per vehicle for 5 to 7 years for overhead and maintenance costs totaling between $5,500 and $7,700. Thus, depending on whether the vehicle is gas, hybrid, or electric, the county saves between $48,000 and $77,000 for each vehicle that is not replaced. Better utilization data will allow the county to identify further opportunities to streamline the vehicle fleet. We will continue to find creative and innovative ways of savings on costs while we prepare for the impacts of H.R. 1. And thank you, and asking for the support of my colleagues today. Thank you.
Okay, we'll go to public comment and then we'll have board discussion.
Thank you, Chair Lawson-Remer. We have 6 requests to speak on this item, 2 in person and 4 requesting to speak by phone. Also note we received 1 e-comment that was neutral. For any individuals that requested to speak on item 21 by phone, please dial into the conference line using the instructions that were provided to you. We'll begin with the in-person speakers. I'd like to invite forward allegedly Audra and Cesar Javier. You'll have 2 minutes to address the board.
says 1 minute. Thank you. Interesting. You guys are funny because you really, some people actually believe you and think you're actually saving us money. But you're not. You're just going to spend it on something else that we don't need. $77,000 for an electric vehicle. Is that really, you feel like that's fiscally responsible to be getting these vehicles and then putting them on the roads that are crap, and then the weight of them just destroys it even more, costing us more money that really isn't going to be spent on the roads. The idea is to get us out of our cars, so I'm wondering how that fits into this. So if that's the agenda, think about how much money we could save if you just got rid of all those cars. So we don't even need them. People can walk and bike, right? And take public transit. I feel like that would be sustainable. You could offer up some, kind of bus pass and stuff like that. Some people can, or, we could give skates. People could do that, you know what I mean? And really just help our greenhouse gases, because I know that is so important to reduce those, right? And that's why we buy electric vehicles, because it reduces those. Because you don't need gas to mine for lithium and cobalt, And, you don't need fresh water, like in the Salton Sea, where they're taking all our fresh water. But that's okay. That is also fiscally responsible when we're trying to make batteries, like 325 million of them, you know what I mean? That's more important. And what else? Then, the data centers, that also takes our fresh water. Who cares? Because we're going to give people back their own sewage. It's good. Those things are fiscally responsible. So I'm so glad you guys are saving us money. Thank you. I didn't know if I was going to get a check in the mail. Is it do we get a refund for the money that we... No? Right. It's just going to go into your pockets. Good job.
Next speaker, please.
Thank you. In my simple calculation, if you are after saving money, thank you. Are we saving lives, Ma'am Rimmer? These fleets are poison-emitting vehicles. The focus should be, how do we make them emit cleaner air? To save lives than money. You are a member of the governing board since, along with Mayor Gloria, along with the absentee Councilman Rivera, a colonizer from Nicaragua. My God, my God. And here we have a then Councilor District 4, whose artists chronicling the crisis in Tijuana River. Now, when the investigations is coming in, they hide those artistic evidences. Where is it now, Ma'am Step? My God, you're saving money and you're not saving lives of children, youth, elderly like us. Now, what is the logic here? Where is the symbolic love of country? Love of people, love of God. My God, we are off the line. Please, let's focus. How could we enforce or to protect people from environmental hazards? That's the killing machine now, tolling the lives, property of San Diegans. Wake up. We are ready to take over.
Thank you. We'll now hear from the individuals that requested to speak by phone. We'll start with our first caller.
Hey, it's Truth. I actually got in. Tara's gone from smashing employees into small building spaces to now smashing employees into carpooling. Tara's trying to see what kind of Trump-style gutting she can do to have more tax dollars for her political pet projects. We might as well call you Tara Trump. Sounds right to me, wannabe queen. Gutting and cutting cars as always. Why not improve oversight and management of the county's union bonus kickbacks and quid pro quos using our tax dollars? Why don't you cut the project labor agreements to benefit your political campaign funders who do a really bad job with their work, just like this board? County employees can't wait to be tracked with GPS, I bet. And having a communist collective car ration system instead of having departments run their departments. Having a tracked 5,000 minimum usage a year means employees are going to drive more, of course, just like in communist countries with harvest standards. Fake it till you never make it. Funny how communists have zero understanding of economic realities. So let me break it down. Are car prices going up or down? Always up, right? So should the county keep underutilized cars for future use or not? But of course, progressives see all this as other people's money. That's why they waste our tax dollars, switching to dangerous and expensive lithium-based cars prone to cancer-causing explosions. If you want to really reduce county retrenchment and county-caused fiscal pressures, why don't you cut down on your 15 slaves to serve you coffee and make dumb social media videos for Manuela to post? Somebody besides me GPS track the spending on that garbage. And since I was skipped on the last items, I'm using the rest of my time to say items 20 and 9 continued. Apparently, transparency and defibs can wait. And item 22 on union kickbacks withdrawn. How about just never bringing that back? What I'm seeing is, Tara, your agenda meeting management has been worse than Nora's, and she gave 2 minutes to speak on every item. Why does the county continue to treat its faux one meeting on 2 days as 2 separate meetings, trying to address general items on Tuesday and land use items on Wednesday? If it's truly one meeting, why not equally split the agenda?
Thank you. Hear from the next caller.
Hey, Consuelo here. So with all that being said, gosh, I'm just reminded that there's never been a better time to leave a broken system and start a better one. But yeah, dream on, Connie Suelo. Okay, so here we go. What I don't truly understand this item, but I just loved what Brother Cesar Javier said regarding, you all love to save money, but not lives. And, you like to ruin the futures of, our children. Our children, leave our children alone. Yes, please do leave our children alone. But you know what? It reminds me of something that I read last week. Imagine if schools actually helped kids identify their strengths by exploring their talents from a young age and growing their skills over 12 years instead of letting them all follow the same routine and leaving them confused in life after graduation. And that just also reminds me of how sick and incestuous the system of politics and corporations and the media and higher education, it's all like they're all in bed together. It's so sick. I don't know. That's just a thought. I know it has absolutely nothing to do with this item, but you know what? These meetings are so boring, but I still have to show up. I'm done.
Thank you. Hear from the next caller.
Do you know why you do the things that you do? Why you push these agendas? Why you go ahead and try to reduce how much we drive? Why we're putting in bike lanes in locations that shouldn't have it, going to locations that aren't open to the public? I mean, I figured out why you went ahead and did that off of Governor Drive. The reason why that took place was they needed to fix that road, but they don't have money for our infrastructure to fix the road. So that's why you guys play all these games with us, and you try to pull more and more money out of the normal people, because people with money are leaving California. People who can't, you're responsible for. And you're going to be responsible for more and more people if we allow fraud to continue to take place. They're going to go ahead and strip the money from you because they want to make money. But all the responsibility, all the blame, all the hatred is going to go to you guys. If you're willing to go ahead and accept that, by all means, continue doing what you're doing. Because when that boiling point hits, I wouldn't want to be in your position regardless of anything. I am glad that you guys stopped me from running. I am glad that you used the court to stop me from running against Monica. I am so appreciative of that because I see the direction that we're moving to. And I see the fact.
Forfeited. Your comments were off topic. Thank you. Please move to the next speaker.
Thank you. We'll now hear from the final caller.
Paul Bold, I'll try to save a few seconds here so you can get out a few seconds earlier. Managing the fleet as a coordinated enterprise asset rather than a collection of separate departmental inventories makes sense, although one must be really cautious in taking vehicles away from emergency services. However, I do not think that GPS trackers are needed or wanted. They may be expensive to acquire and install, and I think we can rely on manual logs to give us the same info for now. I mean, unless you find someone who actually distorts them or whatever. It also appears that county staff have already researched this issue and identified that 104 vehicles could be removed from the fleet. So why not do this and go from there instead of making all this big fuss about reorganizing everything? You know, plan ahead. Thanks. Bye.
Thank you. And Chair Lawson-Remer, that concludes public comment on this item.
Okay, thank you so much. Any comment from any of my colleagues?
I'll move the item.
Okay, we have a motion by Vice Chair Montgomery Stepp. I'm happy to second. Seeing no comments, please vote.
Chair Lawson-Remer, that motion passes unanimously with all supervisors who are present voting aye.
Okay, great. Thank you all so much. It's 12:30. We'll turn it, it's 12:25. We'll be back at 1:30 in session. Thanks.
Board is in recess until 1:30 p.m.